Morning, everybody. Thank you for joining us. We'll start shortly, and we have the Q&A section open for you to drop any questions that you may have throughout today's presentations.
Good morning, everyone, and welcome to our annual Epilepsy Education Day. We're going to go ahead and get started now. As you can see, this is the agenda for today, just to give you a quick introduction on what we will be covering. We're going to be recording our meeting today, so if you signed up, you will get a link afterwards with all of the information that we cover, and we'll also be posting it on our CHOP website. Couple of quick housekeeping items for today. Before we begin, we ask that you complete this pre-survey to help us improve our event and also to provide us some information about what you learn at the end. So we will have a post survey at the end, and we appreciate any and all feedback that you give. We're going to give everybody a couple minutes to hop on and complete the pre-survey, and then we'll get started. Good morning, everyone, and welcome to our annual Epilepsy Education Day. We're going to go ahead and get started now. My name is Dr. Amanda Reeson. I am a pediatric psychologist at the Children's Hospital of Philadelphia. I've been working in the neurology department for about 10 years. And about 5 or 6 years ago, we decided to start doing an annual Epilepsy Education Day to help spread the word and information around specific topics related to epilepsy. And while the whole idea of the day is to help patients and caregivers adjusting to a new diagnosis, we also open this up to a lot of other professionals throughout the country. So psychologists, nurses at schools and beyond, just to help educate everybody about things that we think are really helpful to know about epilepsy. Before we get started, I just want to remind everyone we are recording today's event so that we can send it out afterwards and also post on our website. So please be mindful of that. And we ask you not to post anything confidential or specific to you or your child in the chat, just to keep questions general. And we will turn off the recording before we do the panel at the end. So we're going to go ahead and get started with our first presenter of the day with an introduction to epilepsy. This is Dr. Marissa DeGiovane. Dr. DeGiovane is a pediatric neurologist who specializes in epilepsy. She has been practicing at the Children's Hospital of Philadelphia for over 10 years and is an associate professor of pediatrics and neurology at the University of Pennsylvania's Perelman School of Medicine, where she enjoys teaching medical students, residents, and fellows. She's also the director of the Responsive Neurostimulator Clinic at CHOP and the co-primary investigator of a grant that aims to improve the medical care for children and young adults with epilepsy. She is passionate about improving epilepsy care for her patients. So I'm going to go ahead and turn it over to Dr. DeGiovane.
Thank you so much. Thanks for the introduction. And thank you so much, everybody, for being here. We are all so excited to be doing this day because we all learn a lot from it. And without further ado, I think we can get started. In our intro to epilepsy, this part of the presentation, the main goals are basically just to understand the definition of seizures and epilepsy and the terms that come about related to those, and understand how common epilepsy really is, because you are not alone. I think a lot of people think that it's less common than it really is, because sometimes people just don't talk about it as much. We also want to understand the different tests that help neurologists diagnose patients who have epilepsy and become familiar with the treatments that exist. And I'm going to go through some stuff that is, hey, if your seizures are not responsive to sort of first, second line things, I'm going many steps down the road. So when I talk about this stuff, it doesn't mean that this is every patient, but these are just all of the different options so that you know that there are a lot of options out there. And I honestly won't even cover every single option out there. So to go through epilepsy by the numbers, the Epilepsy Foundation especially likes to quote this number, that 1 in 26 people will develop epilepsy at some point. So it is very common. Again, you are not alone in having epilepsy, or if a family member has epilepsy. So the definition of epilepsy, I think, is important that we understand. Basically, it's if you have 2 or more unprovoked seizures that occur more than 24 hours apart. There are, of course, exceptions to this rule, and I think it's important to note that seizures and epilepsy are not the same. Epilepsy is saying that you have a disease that's characterized by a predisposition to generate seizures, and the seizures themselves are sort of a symptom of epilepsy. And I'd be specific about that because sometimes you can have a seizure without having epilepsy, which we'll get into a little bit in further slides. So by the numbers, about 65 million people around the world have epilepsy. That's actually, I think the number is increasing, but that was the most for one of the data collections. It was from 2013. So at that time, 3.4 million people in the United States have epilepsy, and about 500,000 children have epilepsy in the United States. The number, again, continues to increase as populations grow. So the lifetime prevalence of epilepsy in children who are up to 17 years old is 1%. And of the children who have epilepsy, 30 to 40%, depends kind of on the study that you're looking at, are going to have medically refractory cases, which means that they're going to have harder to control epilepsy that does not respond to 1 or 2 medicines. with a good trial. So with that, though, it is important to note that there is an increased risk for psychiatric, cognitive, and developmental comorbidities, which just means that if you have epilepsy, you're at higher risk for other sort of neuropsychiatric disorders. Doesn't mean you're going to have them, but we just want to be aware to look out for them in case somebody also has them, and we can treat everything together. There are a lot of new cases that come up every year in the United States with epilepsy. So again, you are not alone. This is one statistic, which is about 150,000 new cases of epilepsy in the US every year. And most of the time for those new cases, patients are not going to have an identifiable cause. We're getting better and better with our genetic testing, and we'll talk a little bit about that in other presentations as well. But in the meantime, to know that a lot of the time we are not going to know what the cause of the epilepsy is, but we do have treatments for it. So if we move on to the next slide, I do like to mention that people want to know, well, if you have seizures or if you have epilepsy, does it run in the family? And epilepsy can be inherited, but more often it's not. If a parent has epilepsy, depending on the syndrome, this number is going to change. But when you group like everybody who has epilepsy together, there's a less than 5% risk that their child is going to go on to have epilepsy. And it is more common to have it be inherited in generalized epilepsies, which we'll talk about, or febrile seizures, something like that, and it is not contagious. I think that's another thing that people always wonder about. So then the question comes from, well, where does epilepsy come from? And the way that we like to think about epilepsy as neurologists is one part of your brain sort of an overactive area, because seizures are just sort of an overactivity of the brain. And so it's extra activity that's happening that shouldn't be happening. So we say, hey, is one part of the brain misfiring and causing that overactivity? Or is it the whole brain misfiring all at once, which is often because like your cells just have a higher predisposition to misfire. So when you have one part of your brain misfiring, you're wondering, did you have an injury to that area? Like, did you have a stroke or something like that, or an infection, a tumor, or something called dysplasia, which is like a birthmark on the brain, essentially. So that's something you're just kind of born with. So do you have something like that, or do you have all of your brain sort of misfires at once? And that matters because it kind of affects what medicines we want to use or what syndrome we think you have, in which case also would affect what medicine do we want to use. Epilepsy itself, there is sort of a peak in early life and in later life. So being born is hard, and seizures can happen very frequently in the neonatal period or when you're being born. And then throughout childhood, it's a little bit higher. And then you'll see that it kind of goes down as you get older, after puberty, basically, like after the brain has fully developed. And then it starts peaking again as you get older, and you're at higher risk for sort of other secondary causes like having strokes and things like that as you get older. There are triggers to epilepsy as well. It's not just age dependent, which, as you saw from also that prior graph, that it can happen at any age. It's just that it's more often happening at certain ages. There are indeed triggers to epilepsy as well. So specific time of the night and day, like waking, like around sleep-wake cycles is a common time to be a trigger for epilepsy. If you're sleep deprived, if you're sick, that can be a trigger. If there are flashing lights or patterns, that can actually trigger. And that's why you might see on some rides or things like that people say, to avoid this ride if you have epilepsy. And it actually happened in 1997 when Pokemon was very new. They had in their first season an episode where they had a flashing light going at 12 hertz. So that's like 12 flashes in a second with a full screen of a strobe over a full screen. And it sent a lot of children into the hospital because a bunch of children seized because it had provoked their seizures. Alcohol and drug use can also be a trigger to epilepsy or to seizures. Stress, hormones can be triggers, low blood sugar, certain medicines. And those are all the kind of things that your care team will go over with you. Or if you have questions specifically about, you should ask them, because there are indeed triggers. So if you are noticing something as a care team member, we would want to know. So then the question comes up, well, do all seizures look the same? And the answer to that is no. different people can have seizures, can look different among different people. And in one person, they can look the same, but also one person can have different seizure types as well. So there's a lot that we want to know when we're going through sort of, hey, what do your seizures look like, or what kind of seizures do you see? So different seizure types can also sort of vary by age. So the neonatal, meaning like the just born period, and the infant seizures, like the first year of life, can look very different than other seizures. For example, in the infantile time, if you have something called infantile spasms, you have sort of like head drops that babies just do anyway when they're tired, but the head drops in the seizure syndrome will kind of happen in clusters where you're going like this. Older children may have different seizure types that we see in the movies, like the whole body shaking, but there also may be just one body part shaking versus a quick body jerk like that versus your whole body stiffening out like that, or just changes in your mental state, or even just staring spells. So in 2017, we used to have old names for seizures. So we used to have things you might hear like petit mal or grand mal. Those are technically just older names for seizures that we have sort of renamed to describe what's happening. So when you have focal seizures, we say, okay, your seizures are coming from one part of your brain. So we're going to call that a focal seizure. And if you have focal seizures, you have a focal epilepsy. And then in that, we're going to like sort of sub-describe, okay, is your awareness affected or is it not? And the same with sort of, then we'll go on to say, well, are you having motor signs, meaning do you move with them? Or is it like a sensation or again, a level of consciousness that's changing, something like that. And so for generalized seizures, you just sort of talk about, is it the whole body being affected in a motor way? Like, is your whole body moving? Or is this something that's not motor, which is like an absence seizure that you might hear about, which is a staring spell? And then you can, of course, have unknown onsets of seizures, or if for a type of epilepsy, a mixed epilepsy where you have like both focal and generalized seizures. I think the next slide will sort of go through the algorithm of what we do once we think we've defined sort of what is your seizure type, because again, that may make a difference for what we're treating. So first you diagnose the epilepsy and you diagnose the type of epilepsy. Then you will think about, okay, well, now that we know the type of epilepsy, what are we going to do to treat it? And most often we're going to be giving a medication, but again, we're going to tailor that medication to the type of seizures and type of epilepsy that we think you have. Then, if you have pharmacoresistant epilepsy or medical refractory epilepsy, that's when you've given 2 good trials of medicine and you're still not responding. That is sort of, I say 2 good trials because let's say you start a medicine and it has a side effect of like decreased appetite and your child is not eating and they've lost some weight. So we say, this is not the right medicine for you. We're going to switch. That's not really giving it like a good trial. I mean, you gave it a good shot, but we're not counting that as you have hard to control seizures yet because we had to switch the medicine for another reason. So if you've given a good shot, and it wasn't that you had to switch the medicine at a very low dose because somebody wasn't tolerating it or had an allergic reaction or something, then we say if you have pharmacoresistant epilepsy, we're going to do a little bit more of an evaluation. We're going to say, is it worth trying other medicines? Is it worth thinking about doing some type of epilepsy surgery or putting a device in, which still is surgery, but sort of a different type of surgery? Or are we going to try doing some dietary therapies? And I'm going to go through those other options as well as this presentation goes on. So the first thing in choosing the treatment is starting with the correct diagnosis. So we want to know your seizure type and your epilepsy type, like you said. And then we want to know the seizures, like what are you seeing? Let's say you have one seizure type, then we want to say, okay, for one seizure type, how often are you having them? How severe are they? And the initial goal is going to be sort of no seizures and no side effects. But that being said, if you're having harder to control seizures, we're going to want to know, okay, well, if you're having multiple seizure types, what's your most common type or what's the most debilitating type, the type that really gets in the way of everyday life? Because let's say you have both staring spells and drop down and whole body shake. We might say, We are going to raise medicines all the way up to make sure you don't have any drop down whole body shake episodes, because that's the stuff that you might have an injury from, versus if you're having side effects, we might allow a staring spell a month or something like that. Then we go through the different medication options. But again, first we're trying to say we don't want any seizures and we don't want any side effects. But if the seizures are hard to control, maybe we need to change our medicines and think about different medications. And we'll think about, let's say somebody is having seizures because they're going through chemotherapy for some sort of cancer. We want to make sure that the medicines we choose for the seizures are not interacting with the chemotherapy drugs, for example. And then if we're deciding that we've gone through what we think we need to for medicines and that maybe some other options are better options, we'll think about dietary options like the ketogenic diet or the Atkins diet, like a modified Atkins, which is basically a modified keto diet. And we'll think about surgical options. If somebody has one part of their brain that's always misfiring, we say, can we actually take that area out safely? And would that just cure the problem? Versus, well, we don't think we can take any particular area out safely because maybe that would affect somebody's speech, or maybe that would make them a little weaker on one side. So we're going to think about putting special devices in either the brain or in the chest, which I'll kind of get into, that helps sort of regulate the seizures, in that we hope it reduces the seizure burden for you. And then maybe a combination of the device plus medicines might have better seizure control. Or are there some other surgeries we can do, which we're not going to get into, like all of the epilepsy surgeries, because again, that's for hard to treat seizures. So I've kind of already alluded to this, but if somebody has a single seizure, is it epilepsy? And the answer is no. And so then I want to kind of talk about, well, when is a seizure not epilepsy? Because we talked about all the epilepsy stuff and what sort of how we describe the different seizures and things. A seizure is not epilepsy when you just have one seizure, because usually, so seizures are so common that we say everybody's allowed one seizure of life without necessarily having to start treatment for epilepsy. And the reason for that is most people, if they do have a seizure, about a third, if everything else is normal, like you don't have a reason for your seizures, you've gotten head imaging like an MRI, and it's pretty unrevealing, and your EEG, which is the electroencephalogram, the brainwave test that you put leads on your head to sort of check your brainwaves. If those are all okay, the chances of having another seizure is less than 50%. And so at least another seizure in the next year or two is less than 50%. So we say, okay, we are going to let you have one seizure and we're not going to treat it, and we'll see if you ever even have another one, because there's a less than 50% chance that you will. If you go on to have more seizures, then you may get diagnosed with epilepsy. The other time seizures are not epilepsy are if you have febrile seizures, which are seizures with fever. It happens very often in infants, sort of the range is sort of like 6 months to 6 years. If you have non-epileptic events, that just means, and you might hear a lot of different terms for that, like psychogenic non-epileptic events is another terminology that sometimes people use, or psychogenic non-epileptic seizures is an older term that people have used. So there's a lot of terms for that, but then there's also just sort of other twitching or jerking that ends up not being an epileptic event. And that just means that your brainwaves aren't misfiring to create a seizure, but something else is happening. So sometimes a non-epileptic event is, for example, a baby that has a breath holding spell. So babies can sometimes cry, and then hold their breath until they pass out or almost pass out. And so sometimes people think, hey, is this a seizure? Because we can't tell. I mean, somebody's having loss of consciousness and they're, getting stiff as they're doing it because they're getting really tense as they're holding their breath. And so you do a workup to say, okay, do we think that this is a epileptic event? Like, is it the brainwaves misfiring, or is this a non-epileptic event? So it's not a brainwave misfiring, it's a different problem. Or a different issue. And sometimes it's just normal movements that we're not sure in somebody if they are an epileptic or non-epileptic event. The other types of seizures that are not epilepsy are a lot of the times certain provoked seizures, meaning a seizure that was provoked by something going on. So if you're giving birth and you have eclampsia, a lot of people hear about delivering their babies via like C-section or going faster with the delivery because somebody had preeclampsia. It's because if you progress to eclampsia, you are concerned that you might have seizures during that time. Or if you had a head trauma and you hit your head very significantly, like loss of consciousness, you had a bad car accident and somebody seized immediately in that moment, that would be sort of a provoked seizure from head trauma. Other things are like if you're diabetic and your sugar drops really, really low, that could be another reason that you have sort of a provoked seizure. So there's a lot of times that seizure is not epilepsy as well. And that's why if you do have a seizure, it's important to talk to your doctor about it. So febrile seizures, by definition, you have to have a fever, which in the medical world we consider to be 100.4 Fahrenheit or higher, which is 38 degrees Celsius basically, or higher, without any sort of central nervous system infection, meaning like you don't have meningitis or something like that. And again, the age range is about 6 months through to 6 years is kind of the estimate that we often give. So febrile seizures are really, really common. About 2 to 5% of all children are going to have a febrile seizure, and it's actually the most common type of convulsion or like whole body shaking that you see in children who are under 5 years of age. While the peak occurrence is like, think of like 2 years old-ish, so a little bit less than 2, like a year and a half to 2 years old. That's sort of the peak time that people may present with have a febrile seizure. Doesn't mean that it's not common in the rest of that age range as well. The risk of developing unprovoked seizures or epilepsy after a febrile seizure is a little bit higher than somebody who has never had febrile seizures, but it's not much higher. It's about 2 to 5%, or 2 to 3 times greater risk of epilepsy than in the general population. And then within that, there are certain people who are going to be at slightly like, there are some people where it's a lower risk for progressing to epilepsy, and some people where it's going to be a little higher risk for progressing to epilepsy. And the likelihood that somebody actually has more than 3 febrile seizures is really, really rare. It's really uncommon. Less than 5% of individuals who have febrile seizures will go on to have more than 3. So now that we kind of go through some seizures that are not epilepsy, we want to say, okay, well, in general, just seizures and epilepsy, what do people want to know about it? What do your doctors want to know about it? We want to know what the seizures look like, especially how they start, because how they start can tell us sort of like, well, where in the brain do we think these are coming from? And then we want to know, well, how long do the seizures last? Have there been any seizures that are longer than 5 minutes? Do all the seizures stop on their own, or did like you have to call 911 and did somebody have to administer medication to stop it? Then we want to know, well, how often are they happening? Whether or not they're short or long, just in general, how long is everything happening? And if you do have both short and long seizures, like how long are each of those subtypes happening? Are there any triggers that you've noticed? And we kind of went through some of those triggers. So keep an eye if you are noticing a trigger. And what tests were done in the past. Maybe you were on vacation when something happened. So you went to an outside hospital and they had done head imaging, for example. Like we want to know, okay, well, what has been done so far? And then, and of course, what those results are, if we can get them. And then how have the seizures or other medical problems changed since you were last seen by your doctor? So we can know, is there something new going on or something different, or is it just sort of a progression or an improvement in your epilepsy? So then we go through kind of, if you have had a first seizure, well, what kind of test might your neurologist recommend? So I already kind of started talking about some of that. The EEG is the electroencephalogram, and that is where you put a bunch of electrodes or leads on your head, and it picks up your brain waves. It's just picking up electrical activity. There's no radiation. There's nothing dangerous about it. It's literally just sort of like reading what's going on. Then you can also have maybe some head imaging, and there's a lot of different head imaging that we can do. A CAT scan or a CT scan is something that's fast, but doesn't give us as good of a picture. So it gives us a good picture, but the best picture is an MRI of your brain. So sometimes some people get a CT scan in the emergency room because it's faster. And then when there's time, once you've said, okay, we know that there's nothing that we have to urgently act on, we'll get an MRI of the brain. And we'll look at pictures of the brain as well. And I should sort of give a caveat that for all the stuff that I'm saying, everybody's a little bit different. So this is not all set in stone, and you should absolutely listen to whatever your doctors are saying. I'm just sort of speaking in general terms of what somebody may do. An fMRI is a functional MRI, and that is sort of detecting in real time different blood flow or oxygenation of the brain and seeing what part of the brain is taking up more oxygen or more blood flow, to say like what part of the brain is more active during certain things. So if you need to figure out, for example, we are thinking of maybe doing some surgery on the brain and we want to know where your language area is so that we don't go near it and we don't affect your language in any negative way, we might do an fMRI and have you talk during it to see where is your language. The MEG is when you sort of have both an EEG and an MRI together, and you're looking at sort of if you see any abnormal activity or increased sort of signaling in a certain area during tasks like moving your finger or talking as well. It's sort of another way to kind of localize those things. And then a PET is another image that we may do that's also looking at different uptakes to try to figure out what part of the brain is metabolically more active or less active. And then along after the imaging and all that kind of stuff, there's genetic testing as well that we might consider. But I would say the big categories of tests that we want to do are EEGs, images, or genetic testing or genetic testing. So when do we do an EEG? This is a picture of an EEG in black and white, but we do an EEG when we have, you can go to the next slide because I think we have the list of when to do it, which is a first unprovoked seizure. If you have some complex febrile seizures, we might do them. So it's not just like a quick one and done sort of febrile seizures. Sometimes we'll do it for more complex febrile seizures, but just as a warning, we don't always do an EEG for a febrile seizure necessarily because they are so common. And then if you're having episodes concerning for seizure, we may think about doing an EEG then as well. One of the most common indications that we do an EEG for, or that somebody comes to neurology for, is for staring. And that is important to note. I just bring it up for this talk because you may get referred to a neurologist for staring, and it may or may not be a seizure. Not all staring is seizure. Sometimes if you have a gifted or bored child in the classroom, they may stare more often because they're just literally bored or they've gotten through their work faster. You may have staring because of a seizure. That would be one of the seizure types is an absence seizure. Another seizure type is a focal seizure with impaired consciousness, meaning it's starting in one part of your brain as opposed to the whole misfire of the brain, because the whole misfire is often an absence seizure. One part might be a focal seizure, and then if it spreads to your area that affects consciousness, you can be less conscious or not conscious during the seizure. Sometimes inattention related to ADD or ADHD may be the cause of your staring, or sometimes you're just daydreaming. There's a lot of reasons for staring, and then there's other reasons too, where like you're confused in your staring or you're agitated in your staring. And we might do an EEG if you have any of that. We might do an EEG if somebody just has unusual movements or unusual twitching, or if there's something called tonic-clonic movements, and that's like kind of a movement like that. I can't even do it that well, but those are some reasons to do an EEG. For genetic testing, we are learning so much about genetics, and we're really lucky to have a genetic counselor on this meeting today. And so we'll go through some genetics in a little bit more detail further in further talks. But the future of personalized medicine in epilepsy, I would say, is genetic testing, is one big part of that. Basically, as we are learning more genes that cause seizures, we then say, once you know the gene, you know what the problem is, and then you know how we can sort of try to stop the seizures if we can. So if there's a problem, let's say, in some sort of channel in your cell, and that's what makes your cells more prone to seizures, sometimes there's a problem with the sodium channels, and sometimes they're too active, and sometimes they're not active enough. And therefore, the medicines you give, you might want to give medicines that either block that activity, or you might not want to give those medicines that block that activity, depending on if those cells are too active or not active enough. And so that would be sort of tailoring what medication you're giving based on your genetic diagnosis. Because we say, well, this is why we think you're having seizures on a very microscopic or on an even lower, like more honed in level. If we can identify which genes cause the different types of epilepsies, that's how we're going to be able to sort of develop new treatments. And it's definitely a hot topic in epilepsy. So you might hear people talk about it. And it's also why when we send you to genetics, we will often say, hey, even if you've gone and we didn't find anything 2-3 years ago, we might want you to go back to genetics, or genetics might recommend that you come back to them because they might have new developments in the seizure world or in the epilepsy world that may affect what we're doing. Excuse me. So the next sort of thing to think about once we're trying to figure out if there's a genetic cause is, okay, well, what medicines do we want to use to treat the seizures? And if is not meant to like know every single medicine that's ever out there to treat seizures. I think that's for the medical team to decide. But it's a good graph to just show you that for a really long time, we had like 1 or 2 medicines to treat seizures. And with time, that graph is like getting steeper and steeper, that we're adding more and more medications to be able to treat seizures. New medicines are being developed. I mean, this one is only until 2010. We have a bunch of new medicines since then, and we'll actually talk about at least one of them going forward. So it's the cannabidiol. So that was just to show you that like we are getting more and more treatments medically and other ways like surgery too, to help treat seizures. So even if something is not treatable now, it's always worth continuing to follow with your medical team because we may have new treatments coming out that can help or can improve things in the future. So a lot of people ask about the cannabidiol or CBD because that has been a hot topic as well as it was being developed for epilepsy. So in marijuana, there is THC and there is CBD. Those are kind of the two main components. And people realized that people's seizures decreased with some usage sometimes of marijuana. And it was sort of teased out that it was the cannabidiol aspect of it that was really the reason for the decrease in seizures. Basically the FDA, trials were done and the FDA approved a treatment to treat Lennox-Gastaut syndrome and Dravet syndrome and tuberous sclerosis for patients 1 year and up to use CBD oil or cannabidiol to help treat seizures. So a lot of times, I think, as this was coming out, people had a lot of hope for cannabidiol, and it's a pretty good medicine, to be fair, but it's not any better than some of our other medicines that we try, and it does have its own side effects. It's an oil, and so sometimes you get diarrhea, for example, with it, and things like that. So it's definitely one of the medicines that we think about for seizures, but we might think about some other medicines first, and that's where it's important to be talking to your doctor about what medication we should use. But we specifically wanted to highlight it because I know a lot of people ask about cannabidiol. So if you've gone through a bunch of medicines, when medicines are not working, we might think about dietary and surgical options. So the dietary options, like we mentioned, were the ketogenic diet. You might do a surgical resection or other surgical options, or you might do neurostimulation. And those are VNSs, DBSs, and RNSs, or sort of the neurostim devices. And I'm going to talk a little bit about all of those options too. So we will talk about ketogenic diet, but that's in a couple slides. We're going to start with the surgical resection aspect first. And the reason why we're starting with that first is because it's probably the most effective treatment for medically refractory epilepsy in children who have focal lesional epilepsy. And what that means is that one part of their brain is misfiring and there's a lesion there. There's something there that shouldn't be there. And if we can take that out, sometimes that will stop your seizures. And depending on the workup, there's different percentages of what that chance is. And that's what your neuro team will sort of go over with you. But with the surgical resection, sometimes you can't resect an area that's seizing because either it's a very broad area or because if you do resect it, you might have side effects that we don't want, like you might have weakness on one side or something like that. So if you can't do a resection, there are different neurostimulators, so stimulators of the nervous system that are actually devices that sort of give a little bit of electric current, and you shouldn't feel it, but you will give the nerve a little bit of current or the neurons a little bit of current current so that you try to sort of break up the seizure pattern. And what we found is that wherever you stimulate, whether it be in peripheral nerves, meaning nerves outside of your brain, or inside, if you're doing something inside the brain, about in the first year, it takes sort of time to retrain the system, but in the first year, you hope for a 50% reduction in seizures. Not everyone is going to have that. Some people are going to have even better, and some people are not going to have any effect at all, or not as much of an effect. So the first device that we sort of did to start this neurostimulation was the vagal nerve stimulator that has been around for literal decades. It's technology that's been around since the 80s, trials like 70s, 80s, and there's a lot of patients who have a VNS. About 100,000 patients with epilepsy have a VNS. And in pediatrics, we can implant at a very young age, but the mean age of implantation is about 11 years old. And most people are going to have a reduction in their seizures. But again, not everyone, but we have pretty good rates of having a reduction. So 65% of patients, I should say the overall responder rate is 65%. 41% of patients will have more than that 50% reduction. That is what is required to be a responder. And they might have like a 75% or more reduction in their seizure frequency. So it's very good numbers, but it's what we consider palliative in that you're not curing the problem the way if you can take out a focal lesion, for example, that can sort of remove the problem. This is just sort of retraining your system to have less seizures, hopefully. But it is a really good tool because you don't have the same side effects as if you're doing high doses of medications or multiple medications. So the deep brain stimulator is sort of like the VNS, which I didn't mention with the VNS. It is called the VNS because there's a nerve in your neck called the vagal nerve, and that's what the nerve is stimulating, or that's what the device is stimulating. It's stimulating that vagal nerve for the VNS. In a DBS, it's doing the same thing as a VNS, where it's sort of giving a little electric current, like let's say for 30 seconds it might give a current and then you're off for 5 minutes, or you can change sort of what that cycle is of how often the device is on. But with a DBS, you're doing it in the deep structures of the brain. So deep in your brain is something called your thalamus. And that is sort of like the highway of the brain. So it's thought to be involved in seizure propagation, meaning the relays that go on in your brain from the different neurons of spreading the seizure. So basically we said, well, if we could go to the highway of the brain, can we reduce the seizure frequency if we can sort of stop things in their tracks as they're trying to spread? So the deep brain stimulation for epilepsy was created, and that is your DBS. That was FDA approved in 2018, but it's approved for patients 18 and above. Again, it's for patients who have focal seizures, and if they are not controlled, they're hard to control seizures. Basically, technically, in those trials, it was people who were not controlled by 3 or more anti-epileptic medications. And it's the same idea that in that first year, ideally, you're around 50% reduction. With the DBS, it might take a little bit longer, like it's the first year or two. And then as time goes on for all these neurostimulators, the longer you have them, the more of a reduction we often see. That's what that little chart below is kind of showing, that over the course of 7 years, if you notice, like more and more people will have a more and more reduction in their seizures. The DBS, even though it's FDA approved for 18 and older, we will sometimes, the trials were not done originally in children. And again, this was just approved in 2018. And as you can imagine, trials can take a long time for things to go through all the whole trial and everything and then get approved and by the FDA and become something that we can give to patients. So I will mention that this is off-label, meaning it's not like the FDA approved usage, but we will often put DBS in children, and we do it at CHOP if we think that that's the best treatment for them, because we think that children can also benefit from deep brain stimulation, even though the formal trials weren't done. And there are some trials going on, of course, that are talking about how children are responding to deep brain stimulation. So that might be an option that people talk about. Another option that's also for FDA approved for 18 and up, but we do implant at CHOP, in children is the responsive neurostimulation, or an RNS. This is a little bit different than the VNS or the DBS because it is still sort of giving a little bit of stimulation in the brain. So this one is something that's implanted in the brain. However, the difference with this one is that it's not just sort of like firing on its own at whatever pattern you tell it to fire at. It's responding, it's actually reading your brain waves, and then when it thinks it sees a seizure, it's trying to stimulate and trying to stop the seizure in its tracks, like at the source of where it's starting. So it is for patients who also have focal epilepsy, where they have one or two spots in their brain that have been identified and said, hey, these are where we think the seizures are coming from. And then if we do think that's where the seizures are coming from, these electrodes sort of act in two ways. What we implant in the brain will be able to read the brain waves, and then when they see something that looks like a seizure, stimulate. And with that, hopefully stop the seizure. It doesn't always work, but that's the hope, is that it tries to stop a seizure in its tracks. And for all of these devices, we hope that you are not only decreasing your seizure frequency, but you're making the seizures less severe, ideally, and maybe even shorter or something like that. Just basically, are we improving the seizures in some way? So responsive neurostimulation works like the other two devices, where it's just over time, and that's sort of the graph on the bottom. Over time, more and more people have a reduction and more of a reduction in their seizures. So people will have up to a 73% reduction by year 8 in some of these long-term studies. So all of these devices, they do take time to work. You hope that there's that 50% reduction in the first year or so. But again, with time, it can get better and better. You will level out at some point, of course, and it's still palliative in that we are not taking out the area that's seizing. We're just trying to stop the seizures in its track there. So the RNS is a little bit more responsive. So we're trying to do that overall over time, reducing your seizures, but also stop the seizures in their track as well. And so basically, I think with time for all of these devices, we'll find out the best way to sort of program them, because there's a lot of different steps leading up to your ideal programming step. And it takes time to sort of see what's happening with them, that for every person, it's going to work a little bit different. If we are not going down a device road for patients, be it in your vagal nerve, so more peripheral or less invasive versus like brain, we can think about diet changes. And the diet changes that we think about are the ketogenic diet and the Atkins diet, which is basically like a modified ketogenic diet. The ketogenic diet is basically a high fat, low carbohydrate diet. So the diet at its like a good keto ratio, meaning like a higher keto ratio, is 80% fat, with 15% being protein in your diet and only 5% being carbohydrates. Now, the ratio of the fat to carbohydrates, we vary it. Sometimes it's like a 2-to-1 ratio, but we can try to get to a goal dose of like a 4 to, I say dose because basically that's kind of how I think of it, of your ratio is sort of like your dose. If you can get to a 4-to-1 ratio of fats to carbohydrates, then you can get very ketotic and make ketones, which is what we're trying to do with the ketogenic diet. So ketones are basically, how I describe this to families is that when you are when you're starving, if you're not eating, your body makes ketones as you go. Usually, if you eat something, you automatically go down the pathway to sort of like break down carbohydrates and sugars. And if you don't have carbohydrates or sugars to break down, you then go to the other pathway. That's why, like, if you're starving or something, you go down to the pathway of fat breakdown. And so when you break down the fats, you sort of go down this ketogenic pathway. And somehow it seems that ketones are protective. When you're going down the ketogenic pathway, you make ketones, and that seems to be neuroprotective or helpful to the brain. And people seem to seize less if they are what we call ketotic, meaning they're making more ketones. So the ketogenic diet works for a lot of different types of epilepsy, but it's something that you really have to commit to. You can't like be on the ketogenic diet for a day or for 2 meals of the day, and then the third meal of the day not be ketotic, because your body will automatically default to breaking down the carbohydrates. And so it kind of messes up the whole ketone process. So because it's not without its side effects, and it's definitely doable, but it's something that you have to really commit to. We don't do it right off the bat for most epilepsy syndromes. There are some that we do, but right off the bat, we'll try medicines first. And then if medicines are refractory, or if you're not responding to the medicines, that's when we'll think about going on to the next step, like a ketogenic diet, because we do have to watch, since you're doing such a high fat, low carb diet. It's something we have to watch all to make sure we're not giving you any nutritional deficiencies or anything like a metabolic syndrome or anything like that. So again, it's something that you talk to with your medical team and kind of go through what the best option for you is, but that's sort of another option that we can do. So we have the ketogenic diet outcomes for diets are that there is, again, sort of like the neurostimulators. You want in that first year, it's sort of a slower process to reset the brain to try to make seizures improve in their frequency, at least, that there should be about a 50% reduction at for a lot of patients at a 3-month to like it's at a 3-month interval, but ideally within the first year that you're doing the diet, you have a 50% reduction in your seizures. Again, some people will be better than that. Some people will not respond as well to that. The most successful patients on the ketogenic diet at 6 months are ones, it seems like, who have generalized epilepsy. If you started epilepsy when you're very young, if you started the diet when you're very young, seems like female gender might respond a little bit better. That was with a chart review. Again, that's one study. So we still need to look, I think, a little bit more to say what are the best prognosticating factors for the diet, because there's many, many people that can benefit from the diet. So what we think about is, for if you are not responding to your medicines, can we go down a surgical route? And if it is a surgical route, is it something we can take out? Or is it something, a device that we can maybe put in? Or is there some other surgery we can do, which I kind of didn't touch on, because that's, again, way down the road if you're just not responding to medicines at first? Or can we do something diet related like the ketogenic diet? So those are kind of all the different options for if you're not responding to medicine. So just know that there's lots of different options out there. So things to sort of take home. I know that was a very broad view of like, what is epilepsy? What is seizures? What do we do if seizures are really, really hard to control? And I didn't even get into what are the first line meds for if seizures are easy to control. If you just try one medicine and your seizures are controlled, what do we do? And I will say for that, a lot of times you want somebody on an anti-seizure medicine for at least 2 years for them to become seizure free for 2 years before you think about weaning off the medicine. But people are not necessarily on medicine for life with epilepsy either. We're just trying to treat as best we can in the moment. So what I think you should take away from this is seizures and epilepsy are very, very common. There are lots of different seizure types. And while seizures and epilepsy can be inherited, it's not, it can also just come out of nowhere. It's more common that we don't have a cause for your epilepsy, but it's not contagious. Like, you're not going to get it because you're around somebody who has epilepsy. And there are lots of different treatments available to help epilepsy. So I hope that this sort of gives you an idea that you are not alone. And if you have any additional questions, you can always ask us in the Q&A, or as we're going on, you'll see that we're going to get into more detail on some of these topics that I touched on. Thank you so much to the whole epilepsy education team and to all of you guys for listening, and especially Dr. Freed, who had updated slides previously as well. I think we're set. I'm going to give it back to Dr. Reeson.
Thanks so much, Dr. Dujovne. We do have a couple questions. I think that since we have a few minutes, you might be able to answer.
Yep.
One was, how common is it to lose consciousness as a result of a seizure?
That's a really good question. It depends on your seizure type. So if you have a very, very focal seizure, like just in the area of, let's say, your hand or something, you might only have hand twitching, but a lot of people will lose consciousness if the seizure spreads. So if it's like the whole brain, you might have some sort of impaired awareness. So more common with that, like with the whole brain spreads. As well as if it's in the certain lobes of the brain, like temporal lobe seizures, it can spread very quickly to the area of consciousness faster than some other areas. And so it is really common to have a loss of consciousness with the seizures, but your eyes might be open, but you're not responding. And so we're still considering that like loss of consciousness.
And I think we have time for one more. And if there's any other questions in the chat, we do have a Q&A at 12:30 that we'll answer them in. One more question was, while we've seen an increase in seizure meds over time, have we seen an increase in seizure control as well?
Yes, our epilepsy surgery controls. So we've seen for a very long time, it has been true that if for people who have seizures, just grouping everybody who has epilepsy together that we're starting on medication, most people actually respond to the first medicine you try. It's like 2/3 of people are going to respond to the first medicine that you try. And so that hasn't changed in many, many years, even though our medicines are good, because they've already been responding very well at first. If of those of the 1/3 that didn't respond to the first medicine, about 50% are going to respond to the second medicine. And so for a long time, it's been that most people are easily controlled on their seizures. And honestly, about 90% of kids, if you just group all the kids who have epilepsy, most children are going to grow out of their epilepsy. However, it's for those kids that the less than 50% of the 1/3 who didn't respond to the first two medicines, for those people, our seizure response rate or our control, like your improvement in seizure control has improved over time, but it's just that it's already a smaller population of patients that we're talking about to begin with, because most people have already been responding to their medication. So yes, we have been definitely seeing an improvement in seizure control, but again, it's for a smaller population that was already a harder to control population. And I know we'll address, Dr. Reese, and you had said we'll address the other questions in the future. I do see that somebody had also asked about SUDEP, or sudden unexpected death in epilepsy. And I think we'll get into a little bit more of that when we're talking about seizure detection devices. And if we're not, we can talk about it in the Q&A.
Great. Thank you so much, Dr. DeGiovane. And she will be joining us again during the Q&A from 12:30 to 1. So next I wanted to introduce one of our genetic counselors, Lena Lusk. So Lena Lusk is a licensed certified genetic counselor and has been part of CHOP's Epilepsy Neurogenetics Initiative, or ENGINE, program for 4 years. Prior to CHOP, she worked in adult oncology for 2 years. As a genetic counselor, she manages the ordering of genetic testing, interprets results, explains results in family-friendly language, and provides counseling support to those adapting to a new genetic diagnosis. She specializes in genetic causes of epilepsy, autism, intellectual disability, hemiplegic migraine, with expertise in CACNA 1A, CSLC 6A1, and DUP15Q related disorders. So I'm going to turn it over to her now to talk a little bit more about genetic testing.
Great, thank you so much for introducing me. So we can go to the next slide. So when we talk about epilepsy, as you just heard, there can be all kinds of different causes. Oftentimes we can't find a specific cause, but there are all sorts of different ones. We can have those inherited cases like you heard about. There could be structural changes within the brain. There can be infectious diseases like meningitis that can lead to epilepsy. There can be what are called like inborn errors of metabolism, just different ways that your body is processing things that can lead to like a buildup of toxins in the body. You can have immune-related disorders. And again, in a lot of cases, it's unknown. We could go to the next slide. I'll be focusing here on these genetic causes, which can be inherited, and sometimes even though they're genetic, they're not actually inherited and they're just brand new. So there's different types of genetic changes that can cause this. So the reason epilepsy can be genetic is because our genes are sort of like recipes for making proteins, or all the different components in our body. So they make up the structure and like function of our brains, and our brain is where this epilepsy can come from. So they often are responsible for things like making our neurons, or those brain cells, the way that they connect to each other, the way that they work and function and do their jobs, the way they communicate with each other, and then the way that they conduct electricity or signals from one to the other. Again, it's most epilepsy is thought to be overall due to genetic differences. So even if we can't find one specific cause, we do think that maybe there's lots of little causes that can stack up together. And if there's, these genetic changes that lead to differences in how the brain works, it can lead to epilepsy, or these differences in how these brain cells communicate with each other. So this, the little pie chart shows all the different aspects of things that can cause epilepsy. So that biggest portion is one that we do think is genetic, but this can sometimes be things that are really easy to find on genetic testing and some things that are more complicated. And it also includes things that pass along in families and things that are brand new in one person. So over time, we've learned more and more about these genetic causes of epilepsy. Early on, there's only a few known causes, and it was really difficult to do genetic testing to find these causes. But over time, as our technology has gotten better, our ability to discover these specific genetic causes of epilepsy has skyrocketed. In more recent years, we're finding several new genetic causes every single year. There's new papers coming out all the time. We're doing more and more studies to better understand specific genetic disorders. So even though individually they're rare, overall they are fairly common, and we're just trying to better understand what does a specific genetic diagnosis mean for a family. So again, over time, there's been lots more research, and while it was expensive and difficult to do genetic testing before, it's much easier now. So the question comes all the time, like, who should get genetic testing or genetic counseling? And it really should be anyone with an unexplained epilepsy. If there's not a specific known cause already for epilepsy, genetic testing is warranted. So we say like non-lesional, meaning ones that don't have a specific problem or damage in the brain, and unprovoked seizures. So you can have febrile seizures early on in life that are just considered provoked, or other things where maybe there's a medication that led to a seizure. Those ones, again, have another specific cause. Without that specific cause, genetic testing would make sense. And even with febrile seizures, if there's really a long one or a complicated one, that can often be a good indication to do genetic testing to understand why did that febrile or fever seizure last so long. And then anyone even that has a brain bleed or a brain malformation early that leads to epilepsy could be a reason for genetic testing as well. So especially if there's a baby has a stroke in the womb, that's often a good reason to look into genetics to better understand why that happened. So again, any epilepsy that doesn't have another clear-cut explanation, genetic testing is always warranted. And so how often can we actually find answers with genetic testing? So as I said, our ability to find answers has gotten a lot better over time. At this point, it kind of depends on what other things are going on of whether or not we're able to find that specific answer. Sometimes it's still kind of like finding a needle in a haystack, and we do the best we can, but some things are just easier to find than others. So if we have a child that has epilepsy and otherwise typical development, no medical problems, you can maybe find an answer in 5 to 10% of cases. When there's mild learning differences, that increases to 15 to 20%. And if there's autism or intellectual disability, that can go up to 30 to 40%. If there's other parts of the body that are affected, that can be about 20 to 30% of the time we can find a specific answer. So maybe if that's someone that was born with like a heart defect or has a problem with their kidney or their hearing, again, about 20 to 30% of the time with epilepsy and those things, we can find an answer. When someone has developmental or epileptic encephalopathy, so epilepsy that impacts development, that can be a bit more of a severe disorder, we can find an answer in maybe 30 to 50% of cases. And I think our highest chance of finding something is if we have a newborn baby that has seizures. We can find an answer about 50% of the time. So again, there's a big range there, but there is always that chance that we can find something. So why would a genetic diagnosis be important? What can this actually do? So for a lot of families, it can just be about finding an answer. Like, why does a child have seizures or some of these other problems that can go along with it? And is this something that there was a brain problem, or was there something genetic that this child was born with that caused it? It can also give some prognosis information about what to expect in the future. So it can tell us about the impact to other parts of the bodies. There are certain genetic syndromes that can affect not just the brain and causing epilepsy, but maybe do affect the kidneys or the heart. And this can give us information to know that we should screen or look out for those other types of problems. Can also tell us if this is something progressive, meaning that seizures or the disorder might get worse over time, or if it's something non-progressive that might be stable. And even in some cases, it can tell us that we expect that the seizures will go away on their own. So there's a few genetic conditions where we know that seizures after a year or a certain amount of time, they will resolve on their own. So that can be good news for families that are worried. In other cases, we know that seizures can get more difficult to control, so we can prepare for that. It can also give guidance on specific treatments. So there are certain genetic disorders where we know certain medications or treatments work better than others. So sometimes it's a specific medication. Sometimes I can even be knowing that the ketogenic diet or epilepsy surgery are actually really helpful options for those patients. It can also sometimes tell us that there are certain treatments we really want to avoid. There are certain genetic disorders where we know common epilepsy medications can actually make the seizures worse, or a common epilepsy medication might hurt other parts of the body, like damage the liver. So this can give us information to know which medications we should try, which ones we should avoid. And then it can let us know, even if we don't find something that has a specific guideline for treatment, it can let us know that we don't have to be afraid about using some of those medications that we need to be careful about in some genetic syndromes. And finally, it can give us a range of expected developmental outcomes. So some genetic disorders do impact development. It can lead to developmental delay or intellectual disability, and others we know do not. They don't necessarily affect development, and usually development is typical and there's no learning problems. So knowing, if you have a young child that has epilepsy, there's always these question marks about what can we expect sort of long-term in terms of development. And the genetics can often give us some ideas of what do other kids look like as they get older. And then we can kind of use that as a guideline. Instead of just sort of trying to predict based on the epilepsy, which can be kind of hard to predict long-term. So some other reasons why a genetic diagnosis is helpful, it can tell us the chance that other family members could have the same thing. So with certain genetic disorders, it could mean that siblings are at 50% chance, have a 50% risk of having the same genetic syndrome, or someone that has epilepsy, that their future children have a 50-50 chance of having the same disorder. In other cases, we can know that siblings are at very low risk, like less than 1% chance that we would see this again. So if families are planning to have other children, they don't have to worry as much that they'll see it again. And sometimes we know that it could occur again in siblings, but when it occur again in future generations. So again, it just gives us more information about the specific chance that we can see it again, instead of just more general numbers based on how many times we see epilepsy a second time. There can be clinical trials and specialized clinics for specific genetic disorders. And this is becoming more and more of I think for families, there's lots of new clinical trials that are coming out with medications that are specific to a genetic cause. So there are new medications that come out for epilepsy in general, but for these specific genetic disorders, we can target the actual cause of the seizures that's underlying just the symptoms themselves. And there are more and more specialized clinics for treating these specific genetic disorders. So at CHOP, we have like our ENDD clinic sees patients that specifically have genetic changes in a gene called SDXBP1 or SYNGAP1. And so you have providers that know your specific genetic condition and know what this looks like in lots of other kids. And then finally, there's with having a specific genetic diagnosis and having an actual cause for the epilepsy, it can open up the door for a lot more social support, research, resources, and research. And you can pull up, I think, just the animation here. There are lots of different family organizations for these specific gene disorders. So while there's lots of epilepsy ones and the Epilepsy Foundation, these ones can give more targeted help for families. So again, just other people to talk to who are going through the same things. There can be more resources like financially or education or otherwise, and then lots more research opportunities with the goal of getting to more and more clinical trials and treatments for kids even with these rare genetic epilepsies. So if you're interested in learning more or have any questions, you can always contact us at our email, which is engin, ENGIN @chop.edu. And you can find us on the CHOP website. We have our full clinic there and our team and everything there. But some helpful things I just wanted to highlight, because I know there's some sort of misconceptions about genetics and genetic testing. Most insurance companies do cover genetic testing. So most of our patients end up paying $0 out of pocket for testing, whether that's because insurance covers it completely or labs offer a lot of really helpful discounts. We can usually get testing down to like something that's affordable for families. Only rare cases where there is some out-of-pocket cost. And depending on insurance requirements and states that people are in, we do have video visits available, and we can mail cheek swabs to people's homes. So for most patients in Pennsylvania, we are able to do this, so you don't have to make a trek all the way into CHOP just for the genetic testing. And so, yeah, I think that's everything for me.
It looks like we have one question, and I think we do have a couple minutes. So I'm going to read that out so you can answer. Is genetic testing specific to epilepsy, or is it the same genetic testing that would be used for other medical issues? And then also, is there ever a downside to doing genetic testing?
Yeah, these are great questions. So most of our genetic testing is based on the types of symptoms that you have so that we can cater getting the right test. Not every genetic test can do everything. So the way the genetic testing works is generally the same as it would be for any other medical issues, but sometimes we do genetic tests that are specific to epilepsy. Sometimes we do ones that are much broader. So anytime there's any other learning problems or health problems, really in our clinic or other clinics at CHOP, we often do a broad test called whole exome sequencing, and that's sort of same regardless of what specific symptom you have. But again, sometimes it does need to be more specific than that. And a downside to genetic testing, I think that can just be a personal thing. Some families would rather not know some of this information, especially if there could be other family members at risk, or if there could be other medical problems that come down the line or things that get worse over time. For some families, they'd rather just sort of see what happens and not know ahead of time. I think that often is sort of the biggest downside. With some of the genetic testing we do, sometimes people are concerned about things like life insurance, or if there is like risk for other health conditions because of something. So that's always things that we talk about during our sessions and can go through with it. I think the broader the test, the more likely that some of these downtimes we want to just talk about and the pros and cons of genetic testing. Sometimes we do smaller tests just so that we avoid some of those other potential complications. So hopefully that answered the question.
Yeah, great. Thank you so much for presenting today. We appreciate our genetics team joining. And if you have more questions, please put them in the chat. Lena will be back with us at the end for the Q&A. Okay, we're going to move on to seizure first aid and safety. Our presenter today for that is Dr. Yoon-Ji Moon. Yoon-Ji Moon is a pediatric neurology resident at the Children's Hospital of Philadelphia. She's in her third year of her pediatric neurology residency and interested in general neurology, including epilepsy, neurodevelopment disorders, and functional neurologic disorders. She enjoys working with families from different sociocultural backgrounds, feels passionate about addressing health disparities, and loves learning from and being inspired by experiences of her patients and families. She's going to be presenting today on seizure first aid and safety and also seizure devices. And then after that, around 11 o'clock, we're going to be taking a break, just so you know what's coming up today. So I'm going to turn it over to Dr. Moon.
Great, thank you for that. Can everyone hear me? Is the audio going okay? All right, I'm gonna
Yes,
presume
we
it
can
is.
hear you. You're all
So
good.
I'll start with perfect, thank you. So I'm going to start with some seizure first aid. So these are some things that anyone can do for anyone who's having a seizure or just finished having a seizure. And the mantra is stay, step, side. So the 3 S's. So we can start with stay. The most important thing that one can do is stay when someone is having a seizure. And you're staying to make sure that they're safe, that you're administering whatever first aid they need. You're staying to find out if any additional help, whether it's going to the calling 911 or going to the ED is necessary. But you're also staying because often the people who have seizures, especially the generalized seizures, don't remember what just happened. They may be unconscious, disoriented, confused. So the observer who was there to time the event and describe the event is a really, really important part of medical care that they may receive. And I often really depend on the collateral information that the people who saw the seizure have to dictate what sort of workup and intervention I might want to provide for my patients. The second S is keeping them safe. So I always say try to remove anything that can potentially hurt them. So that involves any sort of restrictive items, which can be ties, necklaces, some sort of scarves that are around the neck. I say remove any glasses, especially for some of the convulsive episodes that can cause abrasions or a little bruising on the face. I say try to keep them away. And then that sort of leads into our next slide, which is keeping them on their side. I usually say, please turn whoever's having a seizure onto their side, keep their head safe, and basically have their mouth face to the side and downwards. The whole purpose of this is trying to protect their airway. So God forbid they're biting their tongue or they have food in their mouth. I want to make sure that none of them is going backwards and choking them. So by putting them into this position, we're trying to keep them safe and having their airway open. To the next slide, I say never try to reach into the mouth and grab things or stuff them with like paper towels or other types of towels to prevent them from biting their mouth, because I think it's a lot riskier to do that. Whereas if you just turn them to their side and keep them open and let gravity do its job, that's probably going to be the best way to keep them safe. Some other things to not do, we don't ask families to restrain their kiddos who's having seizures. If anything, we're trying to keep them loose and open. And then the other thing about what not to do, especially after they just had a seizure, is often for some of the generalized seizures, they're in something called a postictal state where they're still confused and not quite themselves. So I say wait a little bit before starting to offer them water or food, because I don't want them to accidentally choke or aspirate anything when they're still recovering from the seizure that they just had. I do think it's important to note not all seizures are the convulsive type. Some are really subtle, some just involve staring off or losing tone or just having impaired awareness without any sort of motor movements. Even those seizures I do think need to have a little bit of monitoring. So I would still say stay just to make sure that they're going back to their baseline, keep them safe. I don't think they need to be in a particular position, but I do say just lay them down, keep them comfortable, make sure there's nothing else around the area that can be dangerous. And for a lot of these seizures, especially if they're not full unconscious generalized tonic-clonic grand mal seizures, some people say that they can actually hear people talk. So I say, speak to them in a reassuring manner, because that might be helpful for their recovery. Right. So moving on to, let's say you did all the first aid, you make sure that they're safe actively in the moment, but when do you actually ask for help? And I want to caveat that by saying, if you're worried and if you're concerned, it's never wrong to call for help or call 911. But here are some like very specific things where I would definitely recommend that they see a medical professional in whatever setting. So first, if it's the first ever seizure, so they're not someone who has epilepsy, who has seizures once in a while, but this is the first time that they've ever had one, I do highly recommend going to go see the doctor so that they can evaluate, are there any provoking factors for it? Do we need to do anything with respect to like stabilizing them? And is this the first presentation of eventual epilepsy that may or may not be diagnosed? If the seizure itself is very severe, so these are seizures that last for more than 5 minutes, or you're having a cluster back to back without them returning to their baseline, or they're seizures that involve any type of vital sign changes. So you're seeing that they're having difficulty breathing or waking up after a seizure. I think these are all indications that someone else might need more medications or other types of support for them. So please call 911 in these cases. If they have suffered any type of injury for the seizures, so for instance, I've had some patients who had like grand mal convulsions or generalized tonic-clonic seizures who end up having some bruises or facial abrasions or fractures. I think these are all reasons to go to the ED for the seizure, but also to address any type of injury that they may have had. If the seizures occurred in water, this is a very high risk for drowning. So if any sort of seizures that happen in the water, around the water, I would make sure someone takes a look at them. And finally, I think Dr. D had mentioned some of this, but if you have other health conditions, whether that's diabetes or heart disease, pregnancy, liver issues, other types of metabolic conditions, I would go ahead and come to the ED and call 911. Often seizures are a manifestation of some like the severe end of complications for these medical conditions, and it's really important that we address those as well. In terms of when to call 911 for people who already have epilepsy, a lot of my families I find get really, really comfortable with doing all the seizure first aid at home and not necessarily coming to the ED every time they have a seizure. And you will definitely be working with your doctor or other members of your healthcare team to think of a seizure action plan and decide when it is to come in and when it's not. In general, I always say you can always call if you're worried. If you're feeling that the seizure is not stopped by whatever seizure rescue plan or action plan that you've had in place, I would say please come to the ED so that we could sort of go for the second line. Again, if you're having any injuries during the seizure or you're choking with the seizures or having any sort of respiratory challenges with it, I would say definitely call 911 so that we can support you better. Right. So on the topic of rescue medicine, for all of my patients, and I imagine this is the same for any other doctor treating epilepsy, we always think of a seizure rescue plan. And we prescribe a medication, which can be in the form of like intranasal, things that you can squirt your nose, sublingual, things that melt in your mouth, rectal, that is supposed to abort a seizure when it's happened for a certain amount of time. So I would say we prescribe these medications for you. These medications are for your use whenever someone has a seizure that meets the threshold to rescue. And please try to keep them at school or work or whatever is the setting your family member will be in. And it's important to keep it in a safe place. We're trying to not lose these medications as they are really life-saving. And for people who have a VNS, these are things that can be swiped with a magnet. I say please keep the magnet somewhere around you that's easily accessible, whether it's in your ankle or your wrist. This is a sample of what a seizure action plan looks like. They're forms that basically describe, what do my seizures typically look like, how frequently do they occur, and what do I do when I have a seizure. It very clearly lines out the specific dose that you should be giving and the next steps. So these are plans that I always send all of my patients home with, and also forms that you can provide to the school so they also know how to appropriately respond whenever your child has a seizure. Great. And then this is just a summary, I think, from the epilepsy website about the seizure first aid. So to review, the most important thing is staying safe, making sure that you're there to time and observe whatever information you need to, and also keeping them safe on their side, away from all like water and sharp things and things that can tighten them. We're just going to go ahead and expand a little bit more about seizure safety in settings that are particularly dangerous. So whenever someone has a new diagnosis of epilepsy or who's had recurrent seizures, I always say try to be particularly safe around driving, around water, around open fires, or anything or any setting that can be dangerous when you happen to have a seizure. So the first one is water. Epilepsy definitely increases the risk for drowning because if you can imagine, for having a seizure when you're out in open water, you're not able to swim, you're not able to protect your airway, and that can cause a lot of complications. You are still allowed to swim, you're still allowed to take a bath, but I would say make sure that you're supervised in the small chance that you may be having a seizure in those settings. And that involves like having a specific supervisor while swimming. In general, I think all of us prefer showers over baths, but if you're taking a bath, make sure the bathroom door is unlocked. Someone is helping regulate the temperature of the water, and someone is there and available to help if you happen to have a seizure in that setting. These are just like a reiteration of some of the things I mentioned, making sure that people have easy access to come and help if you're in a setting in the bathroom or near water. And having like safety glasses for mirrors and shower doors is also really important. Some other special settings are like if you are very, very high somewhere. So you can imagine if you're having a seizure when you're at the top of this staircase might be dangerous because you don't want them to tumble down. Or if you're climbing a ladder and you have a seizure, that's also dangerous. Or having being really high up for any other tower or like playground setting can also potentially be dangerous. All to say, you are still allowed to do all the things that you normally do. I would just say make sure that you are particularly aware of like the consequences if you happen to have a seizure in a setting where you can fall and harm yourself when you're to lose consciousness. The third setting is when you're driving. Legally, we are required to report anyone with a new diagnosis of epilepsy or who's had kind of breakthrough seizures. I think every state is a little bit different in terms of the law managing those guidelines. So it varies a little bit with respect to when can you start driving again. But in general, if you are actively having breakthrough seizures or you're having epilepsy for the first time and they are not controlled, we do say you are not permitted to drive until we get better control of those seizures. So one thing that we always ask, especially for our teenagers or young adults, is check if they're still driving. Let them know that we do have to report and you should not be driving when you're actively having a seizure. And here at the bottom of the slide are some more links about the specific driving laws for each state that you may be in. And the other setting is when you're sleeping. Not all people have seizures when they're sleeping, but for those people who do, this is particularly important and a little bit dangerous because most people end up having seizures that are not like noticed. As you can imagine, when we're all sleeping, no one is checking up on you, and they might wake up the next morning realizing that something is a little bit off. They're in a different position, they're on the ground, and they might have just had a seizure that no one had seen. We're going to talk a little bit about some of the detection devices for seizures that occur in sleep during the next section. But in terms of general like safety and guidelines, I always say, make sure the bedroom door is not locked so that someone, if they hear anything that happens in the bedroom, can quickly come and provide like first aid and make sure you're okay. And some of the other sort of specific devices we'll get to in our next section. So I'm going to spare some of the details here. Other settings that are dangerous would be kind of near heat sources. So if you're having uncontrolled seizures, I say please be cautious around open fires, stoves, hair dryers, curling irons, anything that can be dangerous if you're to have a seizure. In terms of like specific cooking recommendations, if possible, we would say we recommend electric stoves, safer than gas or other types of open fire. Microwave cooking is overall pretty safe using the back burner instead of the front where you could easily fall into. And then making sure you have any type of guards to open fireplaces, wood stoves, and radiators is important. And similar thing goes to any type of power equipment like the lawnmower, or if you're into woodwork and have power tools that you use around that, just making sure that you have the appropriate safeguards, safety guards when using those equipments, and making sure there's always someone around who can help with first aid if you happen to have a seizure around these equipments. And I always like to compare this to sort of childproofing when you have a toddler, like the babies who start walking and are exploring their environment, getting into electric cords and exploring your kitchen with sharp knives. I find it similar in that you're allowed to do everything, but just making sure that you are extra cautious around the areas that can be dangerous for you, and making sure you also have the safety guards in place to prevent accidents that may happen. So for those who wander during a seizure, like special caution to, again, heights, rails, bodies of water, making sure that you're shutting the door when you're home alone, but also have it accessible for anyone who can come and help with first aid if you happen to have a seizure. And making sure you have pads on sharp corners, avoiding glass tables or any other sharp objects that may be harmful. Non-slip carpeting, it can be helpful so that you don't slip and fall and have further injuries, and having any type of barriers in front of open fires or stoves. And here are a whole host of different types of medical alert bracelets whose purpose is to try to identify seizures and alert appropriate people towards it. I'll talk a little bit more about the specific examples, but there's a whole set of different colors and different designs and different details and what detail functions of what each of these bracelets can do, which is really exciting for a lot of our families. And most important thing is don't keep this to yourself or just with family. It's okay to tell a friend. It's okay to tell your community, because it really is something that the community should know and should be able to support you. I have a lot of first diagnoses epilepsy that I've seen recently who's had their first seizures in college, and their roommates are really, really helpful and supportive and can tell me really great collateral for their friends, or have had people who have for the first time in a workplace. I think it can be a really stigmatizing condition, but you'll be surprised by how many people have it, understand it, and are willing to support you. So please never feel alone if you happen to have someone with epilepsy. All right, I can go straight to seizure detection devices. No one has specific questions. And I want to start with a caveat by saying I have no conflict of interest. I'm not here to promote or advocate for any specific devices. I've learned actually a lot just by kind of preparing some of these slides, and that there is a whole host of different types of devices out there. A lot of them, unfortunately, there's not a lot of systemic review and studies to really prove how helpful they are. But regardless, I think it's sort of encouraging and nice to know what are the options that families may consider if it's something that they're interested in. So some of the topics that we're going to talk about is we'll start with a general overview about how some of these devices work, and then go into the specifics of some of the apps and other resources that are out there. So in general, why would one consider using a detection device? The whole purpose of a detection device is to help identify a seizure when it happens and make sure that you're connected to the right first aid. So notify people so that they can come and help you. And ideally, like the shorter the time to get first aid, the lower the risk of having complications from seizures, whether it's aspirating on secretions or having any sort of physical injury from a convulsive episode, and also administering a seizure rescue medicine in an appropriate amount of time. I do just want to mention SUDEP because I know that was a question that came up earlier. For those who are not familiar with the concept, SUDEP stands for sudden unexpected death in epilepsy. And to be clear, I don't think these detection devices necessarily prevent seizures. But knowing that one of the greater risk factors for SUDEP are seizures that occur during nighttime, I do think the detection devices ideally would help identify or detect a seizure earlier and get appropriate help in a faster manner to decrease the risk of some of these complications. And to reiterate the final point, like the most important thing that anyone can do and everyone can do is make sure that you're taking the medications or the ketogenic diet or whatever your chosen treatment is for your seizure, because that is going to be the thing that decreases your epilepsy or decreases your seizures and thus decrease the risk of SUDEP. So some questions that you may consider in deciding on A, whether or not you want a device in the first place, and B, what type of device you may consider. I think the first question is asking yourself, what do you really want this device to do? And that stems from understanding, what does your child's epilepsy usually look like? Do you want it to detect every single type of seizure, whether it's a generalized tonic-clonic or focal seizures that are more subtle? Do you want are these seizures frequent enough? You know, some kiddos have one seizure their entire life. They're really well controlled and they never have it again. And then you have the opposite end of the spectrum where they have multiple seizures a day. All of them are really short. All of them are benign and not harmful. And is having a detection device that tells you every one of these seizures really helpful is a question that I think only your family member as well as your medical team can help answer. And some of the other more logistical components is this a device that I can wear outside of the home setting wherever I go? And what are the costs, whether it's the financial costs or the psychological costs of having like a monitor constantly? And is that going to outweigh the benefits that a detection device might provide for families? In terms of how they work, they essentially take a variety of different types of input to detect whether or not you're having a seizure, and that may involve your vital signs, your heart rate, your temperature, and it may detect like motion, whether it's a surface EMG, detect motor contractions. There may be a video component to it so that you have a visual description of what's actually happening, as well as EEG, which are those electrodes that Dr. D had mentioned earlier, that's supposed to detect kind of electrical activity from the surface of your scalp. Less common are things that involve like lab values. So detecting a seizure based on glucose levels or hormone levels is really, really hard. The quality of your sleep, as well as sounds. So essentially all of those devices are trying to incorporate a variety of different types of inputs to determine whether or not you're actively having a seizure. Mhm. And so to go into some of the specifics, I think one of the more common ones are wearables. They're essentially external devices that you can have on your smartwatch or rings or bands or whichever other part of the body. There are some examples here. So in panel A is like what an EEG might typically look like. There are these pads that you can sort of put on your head like a hat or like a scalp EEG patch in your forehead. Panel B would be those wearables. I think a lot of us have smartwatches or Apple Watches that are already doing some of these things for us. C would be a seizure detection device that function as sensors to movement and is essentially supposed to like detect seizure-like movements when you're asleep. And then panel D would be an EMG patch that you put in your biceps muscles, and it's supposed to detect like vigorous muscle contraction activity. That's supposed to be a proxy of like a generalized tonic-clonic seizure, for instance. Here are a few apps. Inspire is probably the one that I hear about the most from my families. They record a variety of different vital signs, including heart rate. And there's a button that anyone can press to send the data to the appropriate people, whether it's your physicians or caregivers, so that ideally they can come and help administer seizure aid if they're actually having a seizure. And there are also some other functions that are related to these apps, like scheduling medication reminders or documenting how the seizures look like and things like that. Embrace 2 is another type of app that is a wearable. I think this is one of the few FDA, not necessarily approved, but cleared device for children older than 6 years old. It does require a prescription by your neurologist, and there might be some issues with insurance to getting it, but it can be submitted for reimbursement. And the whole purpose of this is also like detecting possible seizure activity based on these proxies and alerting caregivers or whoever you want to be alerted. Brain Sentinel is one of those apps that use like a surface EMG. It's worn around kind of the biceps of your arm. And the sensitivity and how accurate it is really varies. In terms of the specific number, it's really anywhere between like the 70s to 95% in terms of detecting generalized tonic-clonic seizures, which are those convulsions or grand mal seizures. When placed correctly, I think it tends to be accurate, but I do think it depends on like who is wearing it, how you're wearing it, and whether or not your seizure involves generalized tonic-clonic or muscle contraction movements. SAMI is one of those apps that monitors sleep activity, and there are different components to it. For instance, you have like a video recorder that gives you a view of kind of what is actually happening. It's supposed to be ignoring the normal tossing and turning of sleep and only alerting for more vigorous activity that's concerning for seizures. And there are a ton of options that you can use in terms of like the portability of the app, or having a clock mode, or determining like when you want something to be alarmed or not. The next app is MFit, which often kind of goes hand in hand with the SAMI feature. If you see in the picture, it's a little device that you can plug into the side of the wall, and it's connected to this really thin pad, a sensor that you could put right under your mattress of a twin-size bed. And again, it's detecting like the motion of a seizure activity. It supposedly has a low false alarm rate, and there's no age or weight restrictions. And it's those type of sensors that I think family finds may be helpful for seizures that happen at night when you're sleeping, because it's a monitor that's always there when you're asleep on your bed. Here are some anti-suffocation pillows. I think the whole rationale is it's supposed to have more holes so that it lets the air flow a little bit, and your risk of being like suffocated by a barrier that's impenetrable is decreased. So these are pillows that some families like to have. And then these are less of detection devices and more of kind of apps that help you track seizures. So it's similar to like a migraine diary or like a period app tracker, if anyone uses that. It helps you keep organized in terms of when you're having seizures, if there are any particular triggers, what they look like. And it's a really important data gathering tool that you can use to see, whether or not your seizures are well controlled. And you can also have this data for your medical doctor, who can also help assess whether or not you need to change your medications or other type of treatment for your seizures. These are the implantable devices, of course, that we can't forget. I think Dr. D already mentioned the VNS and the RNS and some of the other type of stimulators that you can implant for those who are medication refractory or who think may benefit from these devices. This is my favorite. Just because I really love dogs. There's a lot of really popular programs for seizure dogs who are trained to detect seizures and respond appropriately. Here are just some links for some of the organizations that provide like medical care dogs, including dogs who detect seizures. Then on the next slide, is just a clarification of what these dogs are trained to do. So you have a seizure response dog. These are dogs who are trained to perform specific behaviors when someone is having a seizure, right after a seizure, and that may involve just staying and making sure they're there to comfort them, or like going to alert someone. So the seizure alert dogs are those who demonstrate specific behaviors before a seizure is about to happen, whether it's because they have specific auras before a seizure, or they notice certain things that their person does before they're having a seizure. So the whole purpose of that is, the dogs seem to be able to sense when their seizures are about to come on, so they're able to more rapidly ask for help or provide kind of safety measures to make sure that when you're having the seizure, you're in a setting that is safe. So I think the key takeaway from this part of the presentation is, devices aren't something that I necessarily recommend for every patient. So it really depends on what your desires are, like what you want these devices to do, what type of seizures you may have. And unfortunately, I don't think any device can 100% detect every single seizure, but sometimes they are helpful. And it's something that I encourage families to look into. And specifically, it's important to do the research. There's so many devices that come out every day, and I can't really keep track of all the different apps and the platforms and the functions that they have. So often the families are much more knowledgeable than I in terms of like the latest app that's available in the market. Third point is, before you do anything, please talk to your neurologist or other members of your medical team about whether or not it will actually be suitable for the seizure type and your needs. And finally, remember that there's always those implantable devices that you definitely should talk to your neurologist about with respect to whether or not you think they may be helpful. And here on the slide are links to some of the apps and some of the programs that I've mentioned during this presentation, and they have a lot of great information on there, so I encourage you to look into them. Here are some really great foundations who provide some financial assistance for some of these products, as well as other programs or other things for epilepsy. So never feel alone.
Thank you so much, Dr. Moon. I'm going to leave that slide up in case anyone wants to take a photo. And just a plug that we will also send a shorter version of our slides with some important key takeaways and resources and links when we also send out the recording. So there'll be more information for you all to access this too. I see that there are a couple questions in the chat. I'm going to hold off and keep them for the Q&A at 12:30 because I think it'd be helpful to get multiple providers who are going to be on the call later's input and how to best support when needing to take a break from driving because of seizures or answering questions about SUDEP and more specifically specific devices. So right now we're going to take a short break, 15-minute break, so everyone can grab a snack or some coffee. We're going to resume again at 11 a.m. and our next presentation in the second half of our day will be more focused on the psychosocial services that we offer at CHOP. So we have Child Life who will be presenting about how to support children with different medical procedures and when they're in the hospital. We have our psychology team who will be presenting about how to support patients and families in coping with epilepsy. And then we also have our social work team who will be presenting on different resources in the community. Unfortunately, our representative from the Epilepsy Foundation couldn't make it today, but we are going to present his slides for everybody as well. So you can see the resources from our local Epilepsy Foundation chapter in the Philadelphia region and the supports that they offer. And then at 12:30, we'll have our Q&A. So that's a look at the upcoming presentations for this afternoon. We'll see you all again at 11 o'clock.
All right, welcome back, everybody. We're going to go ahead to start the second half of our education day. My name is Ko. I'm another neurology psychologist here at CHOP, and I'll be taking over the introduction for the second half. Next, we have our child life specialist, Elena Bryden-Butcher. Elena is a certified child life specialist at CHOP, covering neurology and neurosurgery for the past 3.5 years. She supports patients and families as they navigate their hospitalizations, adjust to new diagnoses, provide diagnosis education, prepare and support patients for tests and procedures, and promote normalization through play in the hospital setting. I'm going to hand over to Elena, and she's going to talk a little bit more about child life services here at CHOP.
Hi, can you guys hear me?
Yes, we can.
Okay, I'm so sorry. I know we tested it all beforehand, and then I think it was like stalling on my computer. It made me re-sign in and everything, and then it wasn't working. So sorry about that.
No worries. I mean, it's technology. It happens. So, well, we're gonna welcome Elena to talk a little bit more about child life here at CHOP.
Yeah, so thank you for the introduction. Sorry again. So for those of you that don't know, who haven't either met myself or haven't been in a medical institution or anything like that and don't know kind of what child life is, I'm gonna go over a quick overview of what the job entails and the services that we provide just in general, and then more specifically about some of the interventions and support that I provide for kids, specifically in the neurology and neuroscience department at CHOP. So reading off the screen, certified child life specialists are bachelor's or master's trained professionals, and we really just specialize in child development. That's a lot of like where the theory in some of our classes and our coursework comes into play. And we are experts in addressing the various psychosocial concerns that accompany stressful or traumatic events. In this case, that is a hospitalization. We're kind of seeing child life services be planted into different various parts of society as well. Like there's newly been child life services in like funeral homes and court cases and things like that. But traditionally, we're pretty much in the medical field. And we really just promote optimal child development and try to minimize adverse effects. So what does that mean in more like layman's terms when I'm explaining my role or like introducing services to families? I really just describe it as being like an extra layer of coping support. So I'm going to use that overall word coping a lot in this little presentation. At the end of the day, there's a lot of really hard things and really stressful parts about going to the doctors and being in the hospital that I know a lot of adults don't even like, let alone children. And so my job is really just to help make some of those hard things easier for kids and their families. So there's a number of ways that we do that. And I feel like I tell families too that we wear a lot of different hats, but a lot of what we do kind of falls into these 4 different categories of play, education, coping, and support. So we can go to the next slide. So education is a huge part of child life and a big part of the services that we provide, and providing education to children and families in the hospital is really crucial. We tailor each of our approaches to each child's developmental level, their emotional needs, with the goal of basically overall helping them understand and cope with their hospital experience. In doing this, we really create like a sense of trust and compliance, which is just going to be better, more beneficial overall for everybody involved, the team, the family. When kids know what to expect and they don't feel lied to, they are going to be more compliant with the cares that they receive in the hospital. The hospital is filled with a lot of big words. It's important that kids can make sense of those words. It's filled with a lot of people that they've never met before, devices, machines, medical equipment. And so by providing education, again, it's just giving them kind of a sense of autonomy and trust in this whole new and potentially scary environment that we're really throwing them into. A lot of times caregivers will ask me, like, how do I even begin to try to explain epilepsy, or how do I even begin to try to explain seizures to a kid? Like, that just seems like a really complex topic to even try to like start. And I agree, as somebody who has worked on this floor for over 3 years now, there's a lot about seizures and epilepsy that even I don't still understand. But it's all about like breaking down those big hard words and that terminology into ways that they can understand. There's a lot of really great books, that 2 of them I have listed on the screen here, that do a really good job of giving like foundation of the kind of language and like the softer language and the developmentally appropriate language that like I would utilize. So I really recommend both of these resources. I send families home with them. You can buy them both on Amazon, but it's a good way to just like start the basis of that conversation. Us as child life specialists are also always more than willing to do like video calls or meet with families during clinic visits. I will get more into that at the end about how to get in contact with us. Sometimes it's just like providing caregivers with appropriate language to utilize, because you guys know your kids best. You know how they learn, you know what they do and don't understand, things like that. So we're here really just to like guide you guys on providing support and education for them. Something else that I like to say is providing education really normalizes the diagnosis. Dr. D kind of talked about it a lot, saying like, you're not alone. I think epilepsy is a lot more common than people realize. And a lot of times these kids have done an EEG, whether that be inpatient or outpatient, and they're quite literally like have the electrodes on their head. They're hooked up to the wall and they can't leave their room. So a lot of times kids have told me like, can you believe I'm the only kid in the whole world that has seizures, or I'm the only kid in the whole world that has epilepsy? And to them, it might feel that way. They might be the only kid in their class or their school or their whole hometown that they know has seizures. But by talking about it and educating them about it, they can see that it's something that other kids are going through. And it really just like normalizes it. If we don't talk to them about it, we don't educate them about it, they're going to think it's this taboo thing. They're going to think it's something that makes them weird or different, when it really doesn't need to be framed in that way. And then kind of starting that conversation, I always encourage caregivers to ask really like open-ended questions when it comes to kind of assessing what your kid knows about their diagnosis already. An example of this that I use all the time when kids come to CHOP is like, tell me what you know about why you're here. Why are you at the hospital? A lot of times kids have picked up on or know a lot more than we give them credit for. But it also helps us just be able to fill in any gaps. Sometimes they know some little tidbits of things that they've overheard at parents talking about or overheard at clinic visits, and we can fill in some of that gap or those gaps in their knowledge, and then really just address any like misconceptions they might have as well. Kids hear things, they over exaggerate things in their mind. They build it up to be something much worse than it's really going to be. So a lot of what we do for education is just minimizing those misconceptions as well and like addressing them. And again, this all ties back into like their trust in the healthcare system, thus better compliance. And with the goal of them taking that with them in the future. Sometimes this might be something that is going to follow them for a long time moving forward. And I want them to feel a sense of trust in their care team and know what's happening and know what's going on around them. We can go to the next slide. So how do we provide this education to children? Kind of what I was saying with child life being, we really study the theory and behind child development and how kids understand the world around them and how they learn and take in information. And so we tailor each of our different interventions and things like that. But this quick little chart that I made is how I kind of frame things when I'm talking to caregivers about how to best approach it with their child. Basically, as kids get older, they understand more complex, higher level abstract thinking. So for those preschoolers, we really need to provide more like concrete education, whether that be through those books that I mentioned on the last page, whether that be through like a teaching doll or like pictures. We have a variety of different resources that we use in the field of child life that we can have available for families as well. But those preschoolers really need like those tangible, concrete examples that they can talk about. And a lot of them don't even have the vocabulary in their mind yet to even know like what a hospital is if they've never had to go to the hospital prior to that. So saying the word, but then also talking about what that means. And I always encourage caregivers to start that preparation with things that they can relate back to their day-to-day life. So if it's wintertime and you're getting dressed and you're putting on your hat to go outside, talk about like, hey, tomorrow we're going to the doctor's and they're gonna put those wires on your head and wrap it up in a hat, kind of like the hat we're wearing right now. So they can relate those things that are going to happen back to very concrete things that are in the moment. School age kids, they're starting to understand a little bit more of that higher level thinking. I always tell families too, those school age kids are getting to the age where they're watching things on TV, they're talking to their peers at school. So they are learning a lot about the world around them, but they're also hearing a lot of things that aren't true. So I really encourage families to do those open-ended questions to be able to address some of those misconceptions. The amount of times that kids have come to the hospital and they have heard on TV, like they see the wires on their head and they think they're getting like electroconvulsive shocks through them and things like that. And so we can just like nip that in the bud and like address those misconceptions. Their peers are so important to them at this age. And so they're talking a lot about what seizures and what epilepsy mean, or they're not talking about it at all. So still using those concrete explanations. School age is where I really use a lot of those books that I put on the last screen. And then lastly, for teens, they really can understand those more sophisticated medical terms. They've most likely heard of epilepsy, most likely heard of seizures. They might not understand down to the nitty gritty what the science behind all of that means, but I think they definitely do have a higher level understanding of the complexities of the human body and things like that, but we can still fill in some of those gaps in knowledge. A lot of times I tell our adolescent population that if they have questions, I want them to write them down in their phone. I want them to write them down on a notebook and ask their care team, because social media is a huge thing. They're going to see things on the internet, and a lot of times it doesn't pertain to them. So rather than getting information from a third-party source online that might not have to do with them, I really encourage them to have more involvement in conversations with their care team and have a seat at the table and pay attention during their clinic visits and when the team's rounding on them inpatient, because they have the cognitive ability to understand that the choices that they're making in their care have outcomes down the line that will affect them. So really just promoting them to be a part of their cares when it comes to educating. So then a huge part, like I said, of what we do for child life in the hospital is coping. Coping with the emotional and psychological stress of being in the hospital. The goal is really just to make the hospital experience less intimidating for kids, managing their fear, anxiety, pain, uncertainty. These are all things that we can help to alleviate through different ways. A big one being providing support before, during, and after different like procedures that they might have while they're inpatient or outpatient. And then just providing like a safe space for them to express their emotions that they might be feeling surrounding their diagnosis or their hospitalization. This isn't to replace any sort of like psychology or therapy that they might already be receiving. We're not trained in that sense, but just having them have a space to be like, this is scary, this is hard, and for us to be like, I know, and you're not alone, and there's other kids that are going through it, and let me tell you some of the ways that I've helped them get through that. So really just more like listening and validating emotions. So like I said, one of the most effective ways to reduce anxiety in kids in the hospital is to really prepare them for things they're about to experience, which again relates all the way back to that like medical compliance and trust. We don't want kids to feel lied to in the hospital. And I want them to have that trust in their care team moving forward. So a lot of common procedures and diagnostic tests that we do, at least for like epilepsy on our unit or like pre-surgical workup, are of course like the MRIs, any sort of like imaging, EEGs, IVs, and then just like overall general like surgery prep if they are going to the OR for something. A lot of times caregivers will say like, I don't think we should tell them, I don't want to stress them out. And I frame it as this, like, we're asking them to do a lot of really hard things when they're in the hospital, and a lot of those things are going to be stressful whether we like it or not. And I feel like expected stress is a lot better than unexpected stress. So for coping support before procedures, we do various different like preparation, whether that be like going through all the steps of like getting an IV, showing them what to expect, playing it out on like a doll, letting them do like hand over hand needle play. Like we do it all in like a safe way. We bring in different like teaching dolls that have like the various like central lines or like the EEG on their head, and go through the steps with like the real materials. And that way, like in the moment when it's actually happening on their own body, they can feel so much more of a sense of like, okay, I know what to expect because we already went over this. In terms of during a procedure, we utilize various like distraction techniques, whether that be through like playing a game on an iPad, using bubbles, light spinners. We have all the fun little gadgets and toys. Deep breathing and guided imagery can assist with like pain management and relaxation. And then lastly, just like a huge part of coping with hospitalization and a huge part of what we do in the world of child life is play. The kinds of play that we do can kind of be divided up into like 3 different categories. So medical play really allows kids to feel like a sense of mastery and autonomy. We bring in like doctor supplies, whether that be like a fake little medical kit for the younger kids, and then moving up to like school age and teens, like real medical supplies, obviously only safe ones. And like anything that involves like a needle, like I said, it's always like hand over hand. But that allows them to really like explore the materials in like a non-threatening way. Again, it can address a lot of misconceptions of what certain things do. And I always like start my sessions by being like, none of this is going to be used on your body in this moment. Like, this is all just for you to explore. And it, again, all ties back to that like compliance and trust later down the line. Therapeutic play allows kids to process while they're playing when they might not have like the words to express how they're feeling. A big one that I do a lot is on the screen that's really big with kids right now is making slime. Sometimes I'm like, we're gonna make some slime. And I'll say, I think I'm gonna make my slime red. Like, what feeling do you think of when you think of red? And most of the time they'll say like mad or angry. And I'll say, can you tell me a time that you have felt mad since being in the hospital? And it really kind of opens the door for that conversation when maybe prior to that they wouldn't have even thought about like telling me that or talking to me about how they're feeling. And then developmental play is literally just playing in the hospital just for the sake of playing. There is no goal associated with it other than just making the hospital a more normal place for kids. We can go to the next slide. And then this is, I think this is my last slide. I'll put a quick plug in for sibling support. So at CHOP and most, I feel like pediatric medical institutions, we really focus on like family-centered care and know that a new diagnosis or hospitalization really affects the whole family, siblings included. And a lot of times when a kid has to go to the hospital, brothers and sisters can feel a lot of different emotions. They can feel afraid, worried, confused, guilty, lonely. They're also hearing and seeing things that they are not familiar with. A lot of times the sibling support that I offer to kids is the same as a lot of the interventions that I provide for the patient themselves, whether that be through like education, supporting like changes in their daily routines. It's really throwing like a wrench in their day as well when their sibling or their caregivers have to go to a lot of appointments or they're away from home. Like it's a change to their daily routines. They're being separated from people that they love, and a lot of times that just comes with a lot of worry and confusion. And so any of that like stress that we can alleviate, we provide to them too. And then a lot of times it's just, we have playrooms on every floor at CHOP, and I know most children's hospitals also do. A lot of times it's just like getting them out of the room and letting them just be a kid with their brother or sister, if that's possible. In this picture, it's like providing support for like, maybe we can't do so much support for an infant because they're so young, and I'm not doing diagnosis education with the baby themselves, but older siblings. And then I think it's going to be spoken about in somebody else's presentation, but CHOP does a really phenomenal program called SIB Shops a few times a year. That's basically just a support group for the siblings of patients at the hospital. And I know a lot of other hospitals do similar things. So we can go to the next. Yeah, this is my last slide. Like I said earlier, this is how you get in contact with me. I am the inpatient child life specialist on the neuroscience unit at CHOP. So a lot of times I don't end up meeting families or patients until they're already admitted, whether that be for like a scheduled EEG admission or they're coming in for surgery. So I also put Sammy Persin's information on. She is the outpatient neurology and neuroscience child life specialist. So a lot of times we divide and conquer, and she will meet with families during clinic or get referrals from social work physicians, psychologists about preparing kids on her end of things for surgery, so that by the time they get to me, I can kind of provide more of that acute in the moment inpatient support. So give her grace though, because she just stepped into this role about a month ago. But that is how you get in contact with us if you guys need. And we are more than happy to provide, like I said, email support, sending different recommendations for resources, video calls with kids and their families prior to coming for an admission or a procedure, and then obviously just like support during actual procedures when they're here at the hospital as well. So thank you guys so much. Sorry about the little hiccup in the beginning.
Thank you, Elena. This is really helpful. And I will say, for us, we often talk with family, especially before medical procedures, especially something new, or for patients, being the first time, we always reach out to you and Sammy. And many families have found it really helpful to start early, as you mentioned, that education piece, so that we can fill in the gaps for kids who may not be familiar with what's coming next, and with facts and informations and pictures are more relevant to what's coming next. So for families who are attending today, if you feel like your child can benefit from working with Child Life, you can feel free to reach out to any of your care team member. That include your social worker, physician, psychologist, or many other members, and we will be able to connect you with our Child Life team to target any kind of questions or concerns that you may have. But again, thank you, Elena, for introducing Child Life services. And next, we're going to invite Dr. Corinna Scotti-Dagnan to represent our psychology team. And Dr. Scotti-Dagnan is a pediatric psychologist specializing in epilepsy. She has been licensed for over 10 years and at CHOP since 2018. Dr. Scotti-Dagnan is an assistant professor in the Department of Psychiatry as associate faculty of the Perelman School of Medicine. She is passionate about educating future psychologists, diversity, equity, and inclusion, and improving how children, teens, and their families cope with their seizures. And Corinna is going to start the presentation by talking a little bit more about emotional health and epilepsy.
Thanks so much, Dr. Ding. You can advance the slide for me. Hopefully by the end of this presentation, you'll get a better understanding about psychological concerns that are associated with epilepsy for teens and children. Appreciate what a mental health provider can do for your family in terms of helping you cope with epilepsy, including different treatment techniques that might be helpful to ask for or inquire about when you're looking to get services. And then finally, discover what is available at CHOP in terms of psychological services, how to access these services, and when to access them. Next slide, please. So we know that children with epilepsy are at a higher risk for developing psychological disorders and have developmental differences. A really large-scale study at the Isle of Wight found that children with epilepsy, you can see, are at a much higher risk than the general population, or even compared to other children with other medical disorders. And I think this really speaks to the brain connection with epilepsy, and this idea that when we're talking about brain-based disease, we are unfortunately also dealing with higher rates of mental health difficulties as well. And there are many different reasons why, specifically for epilepsy, that may be the case. The unpredictable nature of seizures certainly can add stress to both the patient's life, but also the family's life as well. Just dealing with parental stress can be very challenging, having to navigate kind of this new role. As Alana was talking to, maybe if there is hospitalizations or more interventions, you're kind of having to divide and conquer if you have other children at home or other concerns that you need to address, and certainly stigma too. There is a lot of stigma still, unfortunately, associated with having epilepsy, and that can also lead to more stress and some more psychological distress as well. On the next slide, we're going to talk a little bit about some of the most common concerns that we do see in youth with epilepsy. So behavior problems, that's really referring to difficulty with non-compliance, not really following parents or teacher or other authority figures' requests, maybe some more irritability and aggression. We can certainly see increased risk for attention and hyperactivity concerns, mood concerns like low mood or worries, Cognitive and executive functioning deficit, so that is referring to learning differences, differences with memory, could also be referring to some challenges with planning, organizing, and sequencing. And then there are also higher rates of autism as well amongst individuals who have epilepsy. On the next slide, you'll see that there are lots of reasons why, you know, epilepsy and these psychological concerns kind of are going hand in hand. So there are different epilepsy specific factors, such as the age of first seizure, how often seizures are happening, the type of seizure, whether we're having focal or more generalized, if there's a known cause, as well as overall cognitive functioning. And so that really speaks to that kind of brain behavior connection. So if there are some differences in how the brain is functioning, we may also see then some more psychiatric concerns as well. Certain medications, including different types of medications, or just having multiple medications to treat seizures, may also influence psychological concerns in youth with epilepsy. And then those psychosocial factors, so worrying about seizures or experiencing discrimination, just adjusting to this big diagnosis, perhaps feeling a sense of a lack of control over what's happening to their bodies, and then how much social support there is for the teen and family. There are also different life stages that can be more or less challenging. I would argue that every life stage with epilepsy brings its own unique challenges and opportunities. And being a teenager with epilepsy, I think, can present some very challenging situations to kind of navigate as a family. The teenage years are certainly a time where youth are looking to be more independent, figuring out who they are in this world, how they want to operate. And then sometimes with an epilepsy diagnosis, as we've heard from other presentations, we are recommending as a medical team for more parental supervision and more parental involvement, which is kind of counter to this developmental stage. This is a stage where parents may start to pull back a little bit. And so that kind of push and pull of how much do I continue to provide support, and then how much do I allow my teen to be independent, can be tricky to navigate. Driving, I know, is a huge question that kind of comes up with our teenagers. It's sort of seen as like, you know, rite of passage in the teenage years. And this is something that is restricted, obviously, for safety reasons in individuals with seizures who are having ongoing seizures. As teenagers also become more attached to their friend group, learning how to navigate those conversations around when do I tell my friend, who do I tell, what exactly do I say? You know, it's really tricky because we ultimately want to tell people to keep the teenager safe. And the more people know what's happening with them, what their seizure action plan is, right, the safer overall they will be. And this is their personal medical information. So certainly not everybody needs to know this information. But the more we know, the safer, you know, we can keep them. So again, there's sort of this push and pull of not wanting to overshare and disclose a lot of information, but disclosing the right amount of information to keep them safe. Playing sports. So sometimes with, you know, contact sports and devices and things like that, there may be limitations on what sports are permitted or allowed, whether that's, you know, kind of ongoing moving forward or just during certain periods of time, such as like before a procedure or after procedure. And then if we're transitioning to college, kind of figuring out who needs to know, how far away should we go. And then, as everybody knows, college can bring its own unique adventures in terms of sleep deprivation, stress, and then the presence of substances as well. On the next slide, I want to also highlight kind of how epilepsy really does affect the family unit. I think as psychologists, we tend to really focus on the individual, and it really is helpful to take that wide angle lens and look at, how the entire family is functioning. We know that when you have a child who has a chronic medical condition, there is significant increase in parental stress. And again, because of the unique challenges that can come sometimes with epilepsy in terms of requiring more supervision and more parental involvement, sometimes it can affect that parent-child relationship. And as our other presenters have mentioned, siblings also can be affected as well by this diagnosis. We know that siblings of children with epilepsy are also at higher risk for psychological concerns themselves. And this can be related to length of illness and some other factors as well. So, how do we know who needs help? Well, the American Academy of Neurology, in their 2014 update, suggested that at every encounter, screening for behavioral health issues should occur. They did not at this time talk specifically about what that screening could look like. So it could just mean that your neurologist or nurse practitioner or healthcare team are asking, hey, any behavior concerns, how's mood, things like that to kind of screen for it. Or it could be formal screening measures. And in fact, on the next slide, you'll see that in 2017, there was an update to this quality improvement, and they are recommending now specifically to assess quality of life in individuals with epilepsy. This is a measure that looks at many different domains: sleep, cognitive functioning, the impact of epilepsy on your life, mood, and as well as looking specifically at depression and anxiety, just because we know individuals with epilepsy may be at higher risk for developing those disorders. And so you may start to see, as you go through your appointments at CHOP, that you're getting more screeners kind of associated with your visits to look at all of these areas. And that's just in line with the American Academy of Neurology's recommendation. So moving into different types of behavioral health services. So we talked a little bit about, why individuals with epilepsy are at higher risk. We talked a little bit about how it can affect the whole family. And we've got the American Academy of Neurology saying these are important things to talk about. So what kind of maybe pushes families to really seek out that support? We can help, and I say we, meaning behavioral health providers, can help in a variety of different ways specifically related to epilepsy. So one can just be coping with this diagnosis. This is a big change. You're taking medications, you're having doctor's appointments. Sometimes it's just scary to have a seizure, to feel out of control, or that your body is doing something that you're not aware of. And so those are all really big concerns and questions and feelings that can be brought up just with hearing the diagnosis of epilepsy alone, that we can kind of help the youth process and move through. Socialization difficulties, right? So it could be that we were at an age where maybe we're starting to go to sleepovers, or starting to spend more time with friends, or starting, teenagers are driving, or they're getting into cars with their friends. And now all of a sudden parents may say, I'm not so sure about those sleepovers anymore, or only with this family because they know about your seizure action plan and they know how to administer the rescue medicine, or only here because I can get to you, within 5 minutes, or things like that, right? So we're starting again to see maybe some changes from where we were pre-diagnosis to post-diagnosis. Sometimes too, because of the cognitive differences in individuals with epilepsy or other diagnoses, they might have trouble socializing and may need some help with social skills training. We also can help with that emerging independence. So helping families kind of find that right for them balance between youth being independent, but also providing the appropriate amount of supervision to make sure that youth are doing everything that they need to be in line with their treatment plan. Helping with that treatment adherence, whether that is working on pill swallowing to remembering to take medications, or being active in creating a seizure diary, or thinking about more intensive treatments. We can also help with coping with changes over the course of treatment, whether that's starting new medications or coming off of medications. My hope is for many of you on this call who are living with epilepsy, you might get to that point where your neurologist says to you, you've been seizure free for X amount of time. I think it's time for us to maybe think about coming off of your seizure medicines and see how you do. And so, just as scary as it is to start a medication, it can be very scary to taper a medication, because you kind of feel like, okay, we're taking these training wheels off, and maybe I'm not quite ready to do that yet. We can also help with surgery, just thinking about whether or not you're ready for surgery, or what that entails, or some concerns that you might have related to it, as well as if you're starting the ketogenic diet to help with seizures. We can assist with difficulties coping at school, whether that's learning differences that may require a 504 plan or an IEP plan, or just general accommodations, or how people are following through on the seizure action plan, attention being given to seizures. We can assist with talking to others about epilepsy, how to explain it in a way that makes sense to friends and family so that you're getting the support. And then we can also help with all of those comorbid issues that may arise in individuals with epilepsy, like worries and low mood and attention concerns, or impulsivity, or some of those aggressive noncompliance issues as well. So the ways that we help are by following some different general therapies out there. And all mental health providers have sort of a school of thought, or an orientation that they follow. And what I would encourage families to think about is finding mental health providers that adhere to evidence-based practices. Evidence-based practices are therapies that have been rigorously studied through randomized controlled trials involving thousands of patients, that really look at, does this therapy do what it's supposed to do and target what it's supposed to target? And one of the most evidence-based approaches that we have as mental health providers is cognitive behavioral therapy. And cognitive behavioral therapy has been studied for many years. It is effective for a wide range of symptoms, from behavioral difficulties to mood concerns. And it's been proven effective for adults, adolescents, and children. This treatment is usually short term meaning 6 to 20 sessions. Those sessions are typically spaced somewhere between weekly to every other week. And cognitive behavioral therapy focuses on teaching patients and families skills to apply these skills lifelong. And these skills are all rooted in what we call the cognitive triangle, or the association between how we feel, what we're thinking, and our behavior. So, to give an example of how this might work, if our primary feeling is feeling worried about seizures, we might have certain behaviors that accompany that. Maybe we have trouble catching our breath, or we're maybe avoiding taking our medication, or avoiding talking about seizures. And then we might have some thoughts about those worries, about what having seizures might do, or kind of those worst case scenario outcomes that could happen with the seizure. And so what we would do as psychologists is say, okay, let's look at those behaviors. Let's look at ways to help with some of those physiologic responses, teach the body to calm down, use the deep breathing, mindfulness, relaxation. Let's look at ways for you to stop avoiding this thing that's so scary to you, and to approach it in a stepwise manner. And then let's challenge some of those thoughts that you're having. Let's look at, the most likely scenario. Let's think through that worst case scenario and kind of scale that. Is that a hassle? Is that a horror? Will it matter in a week, a month, a year? These are just small examples of how, cognitive behavioral therapy can be used to kind of manage some of those unique challenges that can come with epilepsy. Another evidence-based practice that I want to mention is behavior therapy. This really focuses less on, kind of within that triangle of feelings, behaviors, and thoughts, really focuses on the behaviors and how they're influenced by the environment. This can help families utilize strategies to increase or decrease the behavior. So maybe we want to increase compliance. So the first time I ask you to do something, I'd like you to follow through on that, or decrease certain behaviors, tantrums, things like that. And this is particularly helpful for younger kiddos who maybe just don't have that cognitive awareness, or for individuals who are cognitively limited. So in terms of providers, I did want to give a quick mention, because in the mental health sphere, there are lots of different providers, as you can see on this slide, and it gets very confusing who to go to, why to go to different ones. And so I just wanted to talk through a few of them just to give you some background information, and maybe make a little bit of sense of this. Um, so I'm going to start at the top with the pediatric psychologist. So these are doctoral level providers who not only understand behavioral, emotional, cognitive, and social concerns, but specifically how they relate to a medical condition. So Dr. Reese and Dr. Ding and myself are pediatric psychologists because we have that background in psychology, but also specifically understand the unique challenges that come with epilepsy. In the community, you might find clinical psychologists. Those are individuals that specialize just in those behavioral, emotional, cognitive, and social concerns, but may or may not have that medical understanding. Then coming around to 3 o'clock, we have our neuropsychologists. These are individuals who provide assessments. They are looking at those cognitive challenges, those cognitive differences. They may also look at attention and impulsivity. They may look at memory. They may look at the executive functioning, so planning, organizing, sequencing. So if there is difficulty at school, if there is some question about memory or focus or things like that, that's when you might want that assessment, because they're going to give a battery of tests to kind of look at where is your child compared to gender and age peers, and then make specific recommendations for some learning accommodations that could be provided by the school. Then we have many different master's level clinicians, licensed clinical social workers who are social workers licensed to provide psychotherapy, licensed professional counselors who are licensed to provide psychotherapy, and we have our social workers, our masters in social work, and Ava is going to tell you all about what our social workers can do. And of course, you also learned already from Alana about what our certified child life specialists can do. And last but certainly not least, our psychiatrists. Our psychiatrists are vitally important if we're looking at medications for any concerns, whether that's to help with attention and focus or mood. It's important to remember that everybody else on this wheel can provide more coping support, but not medication support. So that was my last slide for just the references for talking about emotional consent. And now you get to listen to me again for a little bit, talking a little bit about how we like to recommend explaining epilepsy to others. So for this part of the presentation, I hope at the end you'll be able to identify who really needs to know about your child's epilepsy diagnosis, different ways maybe to help disclose this diagnosis to friends, family, and the larger community, and then how do we get support if we're having trouble talking about our epilepsy diagnosis. So on the next slide, I think it's really important to talk about why we want to talk about epilepsy. I feel like we've been kind of sharing this point a lot to kind of reduce stigma, to promote normalization, to provide education. I think it's so important to continue to talk about epilepsy. The more that we talk about it, the more it is normalized, the more that individuals understand and don't make assumptions or judgments about others with epilepsy. And ultimately, I think what is important and what I think can be helpful, particularly for youth with epilepsy, I think it's wonderful for them to understand that, talking about their seizures can, normalize what they're experiencing and can provide education. I think though sometimes that's kind of viewed as external or like a service that they're doing for other people. And so it's also important to recognize that by talking about epilepsy, it can help keep them safe and can also help garner support for them. And I think those 2 points sometimes we're not focused on enough, and why we recommend talking about epilepsy. So moving into kind of the who, what, and how. And I think what's so important about this is it is critical to have youth involved as much as possible. So starting with kind of that inner circle. So the way we've kind of structured this is starting out with those that maybe we interact with the most, and then kind of moving into other spheres. Um, so at a minimum, these individuals really need to know. Family members, so people that are going to be interacting with this individual on a very regular basis, babysitters, daycare, school, and after school care workers. We want to think about activity leaders, sports coaches, um, clubs, religious organizations that you belong to, as well as employers. So, what do these individuals need to know in this inner sphere? What the seizure looks like. I hope that you have already learned that seizures can look completely different based on the individual and where the seizure is occurring in the brain. And so I think a lot of people may assume that seizures look like shaking, and that may not be the case for your child or teen. And so it's really important to let people know what the seizure looks like for your child and teen. They also need to know if there's any activities that need to be avoided. I think, again, sometimes this is where people may make assumptions. Oh, you can't go to a concert because of flashing lights, or you can't get scared easily, or things like that. That may be true if your child has photosensitive epilepsy, but it may also not be true. And so we want them to make sure they're avoiding the activities that need to be avoided, but not being told that they can't do something by other people who don't understand the restrictions that your child has and does not have. We also want to reassure them that they're safe. I think there's still a lot of myths and misconceptions about seizures. And so making sure that individuals around them know, how to keep them safe, that seizure first aid, and most importantly, that last step, how can they help? And so sometimes how they can help is to be given different roles, right? So when I think about family members, some young siblings, they might be able to, if an ambulance is being called, go to the door to greet the ambulance, right? So that way they're doing something, but they're away, from their sibling who's having a seizure. Or maybe they're the ones that get a timer started or going. Or maybe their role is just to go to their room and play, right? So how they can help, sometimes we think about how they can help the individual having the seizure, but sometimes how they can help is by giving space or helping with crowd control or taking care of themselves. Um, on the next slide, we kind of want to talk specifically a little bit about what school needs to know. So school, you'll see that a lot of these, what different people or organizations need to know are pretty similar, right? So we're always recommending what the seizure looks like, activities to be avoided, how to help. What's a little bit different about school is that most schools need that seizure action plan, because most school nurses will have rescue medications on hand, and they need to know kind of the protocol for when that should be administered. They Schools will also need to know what accommodations may be needed. Is there a 504 plan or an IEP? And I know some of this may sound a little bit like mumbo jumbo, but our amazing social worker Ava is going to talk a little bit about what those are. But basically, they are individual plans to provide accommodations for students. And what accommodations are listed? Accommodations could be, if a child has a seizure, they get to make a up a test, right? It could be as simple as that, or an excused absence, right, can be part of the plan for having a seizure or attending a doctor's appointment. Or it could be as complicated as needing, a one-to-one nurse with them, or an aide, or being placed in a special learning environment. So, these plans and accommodations can really range based on what your child needs. And then also the Office of Disability Support Services. So this is at the college level. That is like the equivalent to having like a 504 and IEP, is that you basically go to the Office of Disability Support and then have a service plan initiated. So in preparing to disclose the diagnosis, specifically to siblings or even to family members that maybe are at different developmental ages, we want to really think about what is the age, developmental, and cognitive ability of the individual that you're telling. That way you can kind of titrate that information appropriately. You can use appropriate analogies, and you can give them information that they're going to understand. You also want to start to think about what information is necessary to tell. Do we need to say that the exact diagnosis that the sibling has, or can we give a description of what that's like? Do we need to tell them exactly how rescue medicines are administered, or just where they're kept? We also want to make sure that we're telling the sibling and others where they can go for more information, and that those sites are vetted. So a lot of times where they can go for more information may be you as the parent, or talking to a teacher, or it could be that you then suggest a therapist for the sibling, or meeting with the child life or the sib shops. Can be books that you have in the house that have trusted information that's developmentally appropriate. And then finally, we also do want to consider how the diagnosis will impact them. I think, sometimes we forget about that larger impact, particularly on siblings. And it can be very easy to focus on what the youth with epilepsy needs, and sometimes forget about the sibling in terms of their understanding or how things impact them. And that's important to kind of talk about, help prepare them for as well. On the next slide, we want to think about when we're talking about our diagnosis with peers. So one thing to think about is how often the seizure is happening and the type of seizure. There may be some seizures that you may not disclose to peers because it's not going to impact that relationship, or they may not need that information. So perhaps, a peer that's in class with you in a classroom of 30, they may not need to know that information. Someone who maybe you're on a team with, you're having a sleepover with, you may carpool to school, they may need to know that. If you're having lots of frequent seizures, your class may need to know that. You also want to think about the different activities. Is this someone that you just see at school where you have teachers, the nurse, and other people around? Is this someone that you really see kind of by yourselves, where they would be the peer that would recognize a seizure is happening and then would go and get an adult and kind of tell the adult what's going on? So, it really does depend on your comfort level, how often you're having the seizure, and kind of what are those activities. On the next slide, thinking about high school, many individuals with epilepsy do go on to college or even more post-secondary education, whether that's trade school, graduate school, medical school. And so we really want to think about what environments are best and how to make sure that we have a plan in place that's going to best suit needs. that could mean living on campus. Sometimes that's with roommates, because it might be better to have roommates around that can kind of observe if a seizure may be happening and kind of serve as a safety net. You also want to work very closely with that Office of Disability Services, because they're going to be the ones that are going to make that plan. So they're going to be the ones that will look at if your child or a teen has a 504 IEP, how that can translate to services after high school, as well as different dorm accommodations, right? So you may want to make sure that they are not in one of the old buildings that maybe doesn't have the best air conditioning and heating going on, right? So they may kind of be placed in maybe a little bit of a nicer dorm, so to speak, to make sure that those are in place. If they're on the ketogenic diet, they may need to make sure that they have a refrigerator, available to them. So all these things are important to kind of think about and plan for and talk about. And we have had all of these things accommodated for by colleges. In general, colleges tend to be pretty supportive. I think it's a little bit different than high school, in that, there are laws that are, designed to protect individuals who need accommodations in high school. Once you kind of go to college, each college, while they can't discriminate, each college can sort of decide what accommodations they offer. But I do think they take that role as students as consumers seriously and will give accommodations that are appropriate and necessary most of the time. And last but not least, talking about workplace. So it really is at this stage up to you as an adult whether or not to tell your employer about your healthcare status. It's very important to remember you cannot be denied employment or fired because you have epilepsy. And your epilepsy diagnosis may mean that you might need accommodations to do your job safely and successfully. And then that would be a conversation that's kind of confidential that you would have with human resources at your job to make sure that those supports are in place. So all along the trajectory, there are supports and people that will help you make sure that you are properly accommodated to do the best that you can do, whether it's learning in school, post-secondary education, or in the workplace, to be able to do everything that you want to do while you live with epilepsy. And there are some individuals that don't need accommodations either. So, don't be afraid to ask for what you need and to advocate for yourself. So, in terms of other resources that can be helpful, explaining your diagnosis to others or just learning more about epilepsy, you can see we really enjoy the great Katie Kate. I know that's been up there a few times. In terms of teens, the Ultimate Teen Guide is also excellent. The Epilepsy Foundation has amazing resources on their website, support groups, but you'll hear more about that as well. And then Growing Up with Epilepsy, a practical guide. That is a really helpful book, lots of helpful information. The one caveat that I always give to families about that is that it talks about the whole spectrum of epilepsy. And so sometimes that can be a little worrisome to parents to read about different epilepsy syndromes that may not apply to their child. So if that would be hard for you to kind of stick to the relevant chapters, just know that that may or may not be the book for you. We also wanted to highlight on the Epilepsy Foundation's website all the different kind of resources that they have, including that lifestyle and communication toolkit is fantastic. And I think that is it, and we will hold questions to the Q&A. But thank you so much.
Thank you, Karina. I know we do have one question in terms of support, which we'll address later. But next, we have our awesome social worker, Ava Salim-Najad, to present on supports within our community. Ava has been a social worker at CHAP for over 5 years and joined the Department of Neurology in December of 2021. She's a social worker for the Ketogenic Diet Program, the Movement Disorders Program, and the Resident Clinic. So welcome, Ava, to start her presentation.
Thanks so much. Again, as was mentioned, I'm Ava. I am one of the social workers for outpatient neurology, and I'll be talking to you all a little bit about supports within your community today. So some of the objectives of this presentation will include understanding the role of medical social work, providing education about secondary insurance in the state of Pennsylvania, learning about emotional supports available to the entire family of the patient, discussing the differences between public and private schools as they relate to epilepsy accommodations. And then we're going to talk a little bit about IEPs, 504s, and how to get one for your child. So first off, what is a medical social worker? So I know the term social worker has been thrown around a lot today. We've talked a lot about the different supports as part of the medical team for patients who are newly diagnosed with epilepsy. But social workers in a medical setting or in a clinic setting help to coordinate care for patients who are expected to need a large continuum of services. When children have complex health needs, the medical social worker may work with the whole family. And roles for the medical social worker can include a variety of different things, including providing psychosocial supports to patients and families, linking families to community resources, serving as a patient and family advocate, providing case management services, and navigating barriers to care. So one of the biggest barriers to care for many of our families is making sure that they have sufficient funding to make sure that their child is eligible for all of the services that they may need, both at CHOP and in the community. In Pennsylvania, patients who have a diagnosis of epilepsy are eligible for secondary Medicaid through a program called the PH95 loophole. And this loophole provides coverage for Medicaid to patients with a diagnosed disability. That can include epilepsy, and it can include a variety of different diagnoses that children in Pennsylvania have. But we typically recommend having secondary Medicaid for a variety of different reasons. The main two ones would include increased access to home nursing and comprehensive behavioral health supports in the community. In New Jersey, there's not as clear of a pathway for secondary Medicaid. They do have a program called MLTSS, or Managed Long-Term Services and Supports, but their criteria for eligibility are much stricter than in Pennsylvania. So we do provide families with the information for this, and we can help them with the application process. But many patients who might be eligible in Pennsylvania may not be eligible in New Jersey. So we also want to make families aware of a different program that New Jersey has, which is called the Catastrophic Illness in Children Relief Fund. And this can help to reimburse expenses for healthcare that families are having to pay out of pocket for. And this is primarily for patients who are not eligible for MLTSS. So if you're finding that your family is having to pay a significant amount out of pocket for services or co-pays or other things related to your child's care, we would recommend looking into this program and seeing if your child is eligible for this, as this can help to offset the costs of many different healthcare related needs for your child. For any states that are not Pennsylvania or New Jersey, there is a wonderful website that I use regularly in my job that's called kidswaivers.org. And this will tell you about different waivers or secondary Medicaid programs in your state. I always recommend looking this up because they have a lot of dense information about waivers, and they can kind of help you digest it in a way that makes it easy to learn about without having to read all of the different documentation that you might have to on like your state's website. So it's a very helpful website. I recommend just taking a note of that and keeping that in your back pocket if you need it later. And if you ever wanted to learn more about your state's secondary Medicaid program or wanted to initiate an application if you haven't already, you can reach out to your neurology social worker or to CHOP's Family Health Coverage Program. We do have a program within CHOP that helps our families to apply for secondary Medicaid or other different insurance-related benefits. And they've been wonderful, and they help the social workers out all the time in these applications and processes. So I recommend also taking a note of their number as well. So recognize that epilepsy impacts the entire family and not just the patient who is diagnosed. CHOP runs a program called SIB Shops that I believe was mentioned briefly earlier today. And SIB Shops is a program for siblings of patients with chronic health needs all throughout Children's Hospital of Philadelphia. So it's not specific to just epilepsy patients and their siblings. It's for any patient who is diagnosed with a chronic health need and for the sibling of that patient to be able to kind of process their feelings. And it's a collaboration between social work and child life services. And again, it provides an opportunity for siblings to play, connect, and process with other kids that might have, a very vulnerable part of themselves in common with each other. There's also a simultaneous parent group that runs, and this usually, the SIB shops typically occur once every couple months, and it's usually on a Saturday. If you're interested in learning more about SIB shops or you think that your child's sibling would benefit from this, please reach out to your neurology team or your neurology social worker and let them know that you'd like to talk more about it, and somebody can give you a call to kind of review it and see if your child would be a good referral for the SIB shops program. Many of our parents also seek counseling of their own at some point to manage the stress of having a child with epilepsy. So we also want to talk a little bit more about finding a therapist in the community. So how to find a community therapist. There are a couple different common routes that we'll typically recommend for our families to find a provider close to home. The main two are psychologytoday.com and reaching out directly to insurance. I love psychologytoday.com as a website. I think it is one of the most user-friendly websites, and they offer a lot of different filters that you might not find in just looking through a list of providers in the area. So on Psychology Today, if you go in, you can just type in your zip code and they will bring up a list of providers locally, and you can filter out for a variety of different things, including first your insurance. You can filter out for what kinds of issues you're looking to work through in therapy, different kinds of therapeutic interventions that you might be interested in working through with your provider. And you can also, if you're looking for your child, you can filter for age ranges and, age ranges that the therapist works with, as well as if your child would prefer to work with a male or female or non-binary provider. They have a variety of different options that you can filter for on the service. So I think it's a wonderful, really comprehensive way to find providers that gives you a little bit more personality. Each of the providers have their own biography on there that kind of talks about the different things that they like to work with and things that they specialize in. So that's a great resource. You can also contact your insurance directly, either by giving them a call or going on your insurance's website to find providers that are covered by your specific plan. The number on the back of your insurance call that you would call would be the one for mental health. So there's two different numbers. There is the medical number and the mental health number. The mental health number is going to get you providers in your community who accept your insurance. You can also call the number on the back of your card to get more information about your specific plan and what copays might look like for your plan. Many copays are lower than you may think, and we just want to make sure that our families are aware of how accessible it can be sometimes to find a provider in the community through insurance. As Corinna mentioned earlier, the types of therapists can be PsyD, PhD, LCSW, or LPC. And you might want to ask the therapist that you're working with and therapist that you're looking into if they have experience working with the age range needed or coping with medical changes. So some school supports to be aware of. We're talking a lot about school today, but to kind of break it down into how we're able to assist our families with school-related supports, I want to break it down into public school and private parochial schools. So in public schools, every public school district is required to follow educational guidelines as outlined in legal documents, such as 504 plans, or individualized education programs, or IEPs. If a school is unable to accommodate a student's need, it is the school district's responsibility to locate a school that can, even if it is outside of the district. Now, in private schools, they do not have to follow the same educational guidelines as the public school system. And it usually would require a conversation with the school counselor and the school nurse and the school team as to what they can accommodate and what things might be outside of their ability to support. So the different types of accommodations that you're going to find in a public school district would include an IEP and a 504. So an IEP stands for an Individualized Education Program. And this falls under the Federal Individuals with Disabilities in Education Act, or the IDEA, which mandates free and appropriate education services for children with disabilities. And the IDEA requires that individuals or eligible students ages 3 to 21 receive a written individualized education program, or an IEP. Now, an IEP provides personalized instruction to support meaningful progress in school at no cost to the parents. And IEPs primarily target learning-related disabilities and diagnoses. And in addition to that, they can also include things such as medical accommodations. 504s or 504 plans fall under Section 504 of the Rehabilitation Act of 1973. And that is a federal civil rights law that provides or prohibits discrimination on the basis of a disability. Now, this law requires a written 504 plan setting forth reasonable accommodations that can be made that will be made to give the child equal educational access. And 504s are only really able to target physical and or mental health disabilities or diagnoses, and they typically don't go into specific learning-related disabilities. So what are some of the, I know that oftentimes we hear a lot of these used interchangeably, IEP, 504, it can be difficult to know which one is which. So we want this slide to kind of help lay out a little bit more of the similarities and differences. So IEP's requests must be in writing. IEPs require there be a formal committee meets to put in place an IEP. It is governed by the IDEA, and students are eligible for education in an IEP until the age of 21. In a 504, the request can be made either orally or with writing. It can be completed informally with the school counselor or the school nurse. It is governed by the ADA, and it can be transferred to post-secondary education. What's common about the two is they're both mandated by law. Accommodations must be made at no cost to the family. They're both reviewed on an annual basis, and parents can resolve disputes via mediation or lawsuit. So examples of some accommodations that could fall in either an IEP or a 504 would include things such as the ability to rest in a quiet place as needed, temperature-controlled environments, following a standard seizure precaution, so referring to a seizure action plan. This can fall under both a 504 or an IEP plan, depending on which our patients are receiving at school. Academic accommodations such as tutoring or extra time for assignments, given that learning difficulties may coincide with an epilepsy diagnosis. Accommodations for side effects for medication. So if our patients are experiencing side effects relating to their mood, fatigue, or attention, we want to make sure that the school is aware of that and can accommodate them accordingly. We also want to make sure that if our children are having, seizures regularly that are affecting their attendance, that they have a certain amount of excused absences or flexibility for a doctor's appointment. Recommend reaching out to your neurologist, social worker, or nurse with additional questions about 504 plans and accommodations so that we can best support you in navigating next steps or the supports that your child might need in the school setting. So in some additional supports, you can always request a seizure action plan from CHOP, which will detail what to do in the event of a seizure. Want to make sure that your child's school has information about how to manage seizures as they occur. So we've talked about this a little bit today. If your child does have a rescue medication, this should definitely be provided to the school nurse so that they're able to administer it in the case that your child has a seizure that requires rescue medication to be administered. CHOP can also generally provide a letter of support for any known diagnosis linked needs. So if in addition to your child having, seizures throughout the school day, as we mentioned earlier, if there's different side effects related to their mood, if they're experiencing a lot of fatigue after a seizure, we want to make sure that the school is aware of all of these things and that they're tied to their epilepsy and how to best navigate these needs as they come about. So if you ever have questions about this or you want to further discuss, again, reach out to the social work team. And we're happy to communicate with the school directly to answer any questions that they might have regarding your child's diagnosis. And we would just need a release of information to communicate with your school in order to do that. So some advocacy resources to be aware of if you're having ongoing conversations with your child's school and they're not necessarily providing the accommodations or support that your medical team is recommending and that your child requires in the school setting. Some advocacy resources that we would typically provide to our patient families would include Education Law Center, a county-based ARC agency, the Disability Rights Network, and then there's statewide supports that support families in navigating different accommodation and advocacy-related needs. In Pennsylvania, the Epilepsy Foundation of Eastern Pennsylvania has been very supportive to a lot of our patient families in providing them with advocacy and also education to the school about seizures. And we'll be talking about that a little bit after my presentation. But the one that I give a lot of my patient families is the Peel Center. The Peel Center is a state-based advocacy resource to families that are navigating issues with their school district or wanting additional advocacy for IEP meetings and different things. The Peel Center will, there's advocates that are able to have like phone conversations with you. And if they determine that your school is not providing your child with the appropriate accommodations, sometimes I've had families actually have an advocate attend IEP meetings for their child. So that's a great resource to have. And there's a couple other resources here that are great in helping to answer families' questions regarding school-based advocacy supports. In New Jersey, the SPAN parent advocacy resource is very similar to Pennsylvania's Peel Center. So essentially, you can work with advocates to kind of navigate school-related concerns, and they can support you in upcoming IEP meetings, providing you with like vocabulary or different, sources to provide to the school for any questions that they may have. And there's a couple other advocacy related resources for that state as well. So what happens after high school? We've already talked about the fact that many of our patients go on to secondary education and even post-secondary education if that's something that they choose to do. Regardless of what your child's interests are, what they're looking to do after high school, many of our patients will work with the Office of Vocational Rehabilitation if they're finding they might need additional accommodations, either if they have like developmental disabilities or they're having issues with finding a job that's a good fit for them. The Office of Vocational Rehabilitation works a lot with our patients in navigating transitioning to the workforce, what that looks like, and how to best support them in a workplace after high school. So you can connect with your college's disability office if your child is having questions about what kinds of accommodations they might be eligible for. And oftentimes, CHOP is willing to provide children with different, accommodation letters for college. And also, if you already have a 504 or an IEP in school, we want to make sure that the college that you're going to knows the accommodations that you're receiving in high school so that they're able to transfer them in an appropriate way to a secondary education setting. Colleges and workplaces, as we've already mentioned, do not know about your diagnosis until you tell them. So it is entirely up to you whether or not you disclose. But they're not able to discriminate against you either. So if you do choose to disclose to them, you can provide them with any number of resources and supports to be able to accommodate you according to whatever your child's specific needs are. So community supports. The Epilepsy Foundation will present after this on how to get involved in further advocacy, support, and education in your community. There are many other diagnosis-specific organizations as well for support and awareness, and there are a lot of Facebook advocacy for specific diagnoses, but we always recommend, while we love the fact that our patients are able to, kind of congregate on Facebook and utilize social media as a resource or a support in finding other families who have a child with epilepsy. We just want to be careful when it comes to any medical advice that you find on the page. If you have any medical questions, please always defer to your child's medical team before seeking it out or accepting it from Facebook. So just a word of caution whenever it comes to anything on social media. Just always defer to your child's medical team for questions. So for ongoing social work support, please reach out to your child's care team. If you don't already know who your child's social worker is in outpatient neurology, if you have any questions about that, you can always send a message to your child's care team, and they can direct you or direct the question to the appropriate social worker who can connect with you. So you can reach out to social work support either via MyChat by sending a message to your child's neurology provider to say, "Hi, I have a social work need. Can somebody give me a call to discuss?" And one of our social workers will be able to reach out to you. Or you can call CHOP Neurology at 215-590-1719 and connect to your child's social worker for additional support or resources. Thank you very much.
Thank you, Ava. That was really helpful to know about all the different resources that are available at CHOP and also in our community. And before I forget, if your child or teen or ever consider a surgical, device, CHOP also has a program called Family Ties, where they connect families who have had similar experience so that you can get connected with them to talk through what surgical experience was like specifically to the device that you might be consider. Again, that's another, well-vetted program where you can get a lot of helpful information. As Dr. Reason mentioned earlier, unfortunately, Andrew from the Epilepsy Foundation is not able to present today, so I'll do my best to present the wonderful resources from the Epilepsy Foundation to you all. If you have any follow-up questions for Andrew or Epilepsy Foundation, feel free to drop them in the chat or Q&A section. We'll do our best to answer those questions, but if there's any that I don't know the answers to, I would definitely collect them and send to Andrew so that we can include some of the answers in the resources that we'll send out later, so you will find answers to your question. But as Ava mentioned, that the Epilepsy Foundation is a great resource that we recommend to all of our families to consider. And I'm going to briefly talk a little bit about some of the programs and services that they offer. As mentioned, the Eastern Pennsylvania of the Epilepsy Foundation serve 18 counties in Eastern Pennsylvania, and they focus on education, support, and advocacy. And as they have been here with us for 50 years. They offer a variety of different programs and services, not only for our patients, but also for their family members. And here's a list that includes different types of programs and services that they offer throughout the years. And I will be highlight a couple here, but often I recommend family just go onto their website when you have some free time to peruse different information, different programs that you or your family members might be interested in participating. First is information and referrals. The Epilepsy Foundation also works very closely with our neurology division in terms of providing support. They also offer a lot of different educational resources on their website, including kind of discussing with school about different epilepsy education and different accommodations that your child and teen might be eligible for. And they also offer a variety of different support groups for different age ranges. And some of these support groups might be in person and others might still be virtual. So a lot of times that we recommend families to look on their website to see, what are some current support groups that are ongoing that their child, teens, or family members might be interested in. I know earlier there was a question about support for siblings who are older. We often refer family to Epilepsy Foundation to look at some of the virtual or in-person support groups for older siblings that may not be eligible for our SIP shops here at CHOP. And often, at least in psychology kind of visits, we also talk a little bit about if at any point the sibling can benefit from individual therapy, that can also be a protected time and space for the sibling to talk about their own coping and adjustment living with a sibling who manages epilepsy. As mentioned earlier, Epilepsy Foundation also work very closely with schools to provide education and trainings to make sure that they understand and provide support appropriately for our students who are managing epilepsy. I also wanted to highlight a couple kind of community events for our youth. Many of our child providers are very familiar with Youth Achieve and Camp Achieve, and many of you probably have heard about Camp Achieve from your neurologist as well. If I remember correctly, I think enrollment opens on February 3rd. So this is a wonderful camp that offers to our kids between the ages of 8 and 17. And I really appreciate this camp because it allows our patients with epilepsy to really enjoy a variety of different summer activities safely. Our CHOP psychology and social work team also spend a day there with our campers to learn about different activities, to support them to build confidence, courage, and self-esteem. And many of our patients have provided feedback that was a great way for them to get connected with other kids and teens who are also manage epilepsy and really enjoy summertime together. So if you are interested in Camp Achieve, feel free to, look at their website for more information. And you can also talk to your neurologist a little bit more about Camp Achieve and to see if that will be a good fit for your child this summer. Additionally, Epilepsy Foundation also offers Superstar sibling boxes that include a kit of social emotional tools and toys and activities to support our patients and their families and their siblings for their coping and adjustment. Again, their website offers a variety of different information and links to look through these resources. I know sometimes they can be overwhelming to look at all these wonderful resources and programs. So often, I recommend family that if you have maybe 10 minutes on the train ride, or, other times you're waiting for your child at their sports event, that might be a time to peruse some of these awesome programs in our community. As mentioned earlier, Camp Achieve is for kids and teens between 8 to 17. We also have a young adult retreat for young adults between the ages of 18 and 30 years old. And this is also an in-person retreat that will be happening in May. As I mentioned earlier, if you're interested, feel free to reach out to the Epilepsy Foundation or talk to your neurologist to see if this will be a good fit. Again, if you have any specific questions about Camp Achieve or Young Adult Retreat, feel free to drop in the chat, and I'll definitely collect those questions and send it to Andrew to get some answers for you all. As mentioned earlier, not only Epilepsy Foundation have a lot of great programs for our patients, they also try to raise awareness and to our community about epilepsy. I know I participated in the epilepsy walk in the springtime. I think usually happens in June. That's open to public. That's a great way to get connected with patients and families. And it's also just a wonderful kind of day out, in pre-summer day with family. They offer a variety of different snacks and drinks and different activities for kids and teens to participate in the park. If you have any questions about the Epilepsy Foundation, feel free to drop in the chat and I'll send it over to Rena and Andrew. As I mentioned, this is just a wonderful, wonderful resource that really offers a variety of different programs that have been really helpful and supportive for our patients and families. So I'm going to stop sharing so that I can also pop the link to our post survey. As Dr. Reason mentioned, this is a way for us to collect feedback for you all so that we can continue to improve our epilepsy foundation. So feel free to use, I'll pop the link in the chat and then I will reshare so that you can use the QR code. So bear with me for a second and I will pop the link in the chat. All right, so I'll give folks a couple minutes to complete the survey, and then I will stop sharing and stop recording to start our Q&A session. As folks are wrapping up their post-survey, I also wanted to take a minute to talk a little bit about the adjusting to a new epilepsy diagnosis group therapy that's supported by our psychology team. Currently, we're gathering some information from families who might be interested in the support group. So this will be a support group for kids and teens between the ages of 10 and 13, and we will also have a concurrent parent group happening. It's relatively short term, about 4 sessions, and it will occur between our Philadelphia and NKOP campus. So if you're interested, we also have a QR code here. If your child is between the age of 10 and 13 and who recently received a diagnosis of epilepsy. I will also pop the link in the chat as well if the QR code is not working.